Good morning, everybody. Today we have the Pension and Health Benefits Committee. And we'll call the meeting to order and roll call, please.
Ramon Rubalcaba,
Present.
Kevin Palkey,
Good morning.
Malia Cohen,
Here.
David Miller,
Here.
Arena Ortega, Jose Luis Pacheco, Teresa Taylor, Yvonne Walker, Melissa Willette.
Thank you very much. The next order of business is the election of the chair and the vice chair of the Pension and Health Benefits Committee. For this, I will hand that gavel over to Kevin Palkey, vice chair.
I will now take nominations for Chair of the Pension and Health Benefits Committee, and I would like to nominate Ramon Rubalcaba. Is there a second?
I would like the second.
I have a motion and a second. Are there any other nominations? Are there any other nominations? Are there any other nominations? I have a motion to approve Ramon Rubalcaba as chair. All those in favor say aye.
Aye.
All those opposed? Any abstentions? Motion passes. Ayes have it. Congratulations, sir.
Thank you. Thank you, everybody, for your vote of confidence. So now I will take nominations for vice chair of the Pension and Health Benefits Committee, and I will nominate Kevin Palkey as vice chair of the committee. Thank you. Second. Nomination is made. Are there any other nominations? Are there any other nominations? Are there any other nominations? So I have a motion to approve, motion to approve Kevin Palkey as vice chair. Let's call the roll. Everybody, all those in favor, please?
Aye.
Aye. Any abstentions? The ayes have it, so congratulations, Kevin Palkey. Okay. Now, unfortunately, we will have to call the meeting into closed session. We will recess into closed session for items 1 through 5 from the closed session. It will be approximately 2 hours. So thank you for your patience and understanding. We're back in open session and we'll continue the remainder of the open session agenda. Please call the roll.
Ramon Rubacava,
Present.
Kevin Palky,
Good morning.
Malia Cohen,
Present.
David Miller, Lorena Ortega, Jose Luis Pacheco, Teresa Taylor, Yvonne Walker, Melissa Willett.
Thank you. Before we go into executive report, I want to thank the audience for your patience where we were in closed session. And in the future, we will endure to try to see we can move do the open first and then a closed. Okay, now we'll proceed with the executive report. Mr. Moltz.
I think Ms. Malm was going to go first, if that's okay.
Okay, yes.
Thank you.
Sorry.
Good morning. Kim Malm, CalPERS team member. This morning, I thought I would just give you a couple of updates on projects that will impact our members that we're working on right now in the Customer Support Services branch. First, I'll start with the 2025 Benefits Verification Project. As you recall, last year, we conducted a benefit verification cycle for high-risk retirees. We used to do this every 2 years. This last year, we decided to conduct this cycle annually to prevent overpayments due to unreported member deaths. With this project, we request the certification of eligibility for payment form to be notarized and sent in. The retiree could also send in a letter from their healthcare provider, or a letter from the care facility that they live in, or a letter from their bank. And once we receive that, then the benefit payments would continue. Of course, if members have any problems or have any questions, they can contact our call center or they can go through our secure messages in their CalPERS account. We're kicking off the 2025 cycle on March 27th, so at the end of this month. We'll be sending letters to 10,000 retirees that meet certain risk thresholds, including age, benefit amount, the last time they contacted CalPERS, and the last time that they've contacted their healthcare provider. These same members will receive a second notice at the end of April and a third notice at the end of May if they've not responded yet. We'll be letting them know that we will hold their August 1st payroll benefit check if they have not received before our roll closes on July 18th. As a reminder, last March, our benefit verification cycle included 8,700 letters to retirees. From that effort in 2024, over 200 deaths were reported across California and in 24 other states. Those unreported deaths resulted in $2.2 million of overpayments, of which we've collected $1.7 million so far. Also, in July of 2024, we began utilizing SoCure as our death verification vendor. To date, they've reported over 460 deaths for us, resulting in $4.1 million in overpayments, and we've collected $3.3 million so far. The combined benefit verification project and the death verification with SoCure have found almost 700 deaths, with a little over $6 million of overpayments and $5 million collected just in this last year. Now moving on from benefit verification to its mother project, overpayments, I thought I would give you an update from my presentation from Finance and Administration Committee last November. Our teams continue to collaborate internally to strengthen the collection process. Recently, our legal office entered into a contract with a collections firm, Cedar Financial, that will assist with recovering debt from across the United States, since deaths are occurring in numerous states, as I mentioned previously. The actuarial office has also been working with us to develop tools for quick identification of calculation errors. This initiative corrects errors and addresses root causes, leading to improved payroll edits that help prevent future discrepancies. In fact, recently, the working team found inaccurate scheduled work hours reported by employers in their payroll data. This could have led to inaccurate final compensation. Such errors can cause benefit adjustments and potential overpayments that might only be caught in an audit and must be identified within the first 3 years in order to recover the funds. I continue to be so proud of the enterprise team and all they've accomplished in this area. I'll close with an update on our CalPERS benefit education events. We concluded our first in-person CB of 2025 in Visalia on March 7th and 8th with 439 attendees. Two of them were so excited they retired on the spot. Since our last meeting, we also had a virtual CB that took place on December 11th and 12th with over 1,800 attendees. Our next in-person CB is in Burbank on April 11th and 12th, and registration is now open. As of this morning, we had close to 1,000 people registered. Other planned CBs for 2025 are virtual in June 11th and 12th, and another one will be planned for either August or December of this year. The next in-person CBs will be in 2026. The first one in Monterey, January 9th and 10th. The second one in Anaheim, April 10th and 11th, and then Reading, June 5th and 6th. And that concludes my comments, Mr. Chair, and I'm happy to answer any questions.
Thank you. Does the committee have any questions? Seeing none, I just say thank you.
Thank you so much.
Don?
Thank you, Mr. Rubalcava. So first, my team and I would like to congratulate you and Mr. Palkey on your reelection as chair and vice chair. You've been great leaders and partners, and we're looking forward to working with you again this year.
Thank you.
Have a handful of updates. On December 5th, the CalPERS health team hosted our latest health policy roundtable, which continued the discussion from our July 2024 board offsite on healthcare workforce challenges and opportunities in California. Expert panelists from the California Healthcare Foundation, Department of Healthcare Access and Information, Department of Healthcare Services, and Covered California joined the CalPERS team and two members of the board to talk about California's healthcare workforce and discuss opportunities to mutually address access challenges that public purchasers face and leverage their influence as large purchasers to affect that change. A summary of the meeting along with key takeaways will be available on the website later on this week, but in general, the focus was and will continue to be using the collective influence of the four public sector participants to improve access and address California's workforce challenges. The next health policy roundtable will be at the July board offsite. We will be focusing on the important question of artificial intelligence in healthcare.
That sounds like an excellent topic, and we look forward to reading the summary and the website
Great.
of the
Yeah.
December one.
Yes.
Thank you. Please proceed.
Thanks. So on March 5th, CalPERS hosted approximately 50 health plan medical directors and clinical staff as part of our first joint clinical leaders retreat in partnership with Covered California. National speakers from the American Board of Family Medicine, the Institute for Clinical and Economic Review, and my former employer, the Commonwealth Fund, led discussions related to the importance of continuity of care, affordability, and access to prescription drugs, and vaccine hesitancy. The planning team facilitated breakout sessions with the health plan medical directors who engaged in productive conversations that yielded important takeaways and next steps. Participants seemed genuinely engaged and appreciative of the opportunity to meet as colleagues rather than as competitors. It's gratifying to observe a high level of interest and engagement from attendees, much of which could be attributed to the Covered California CalPERS committee and their thoughtful planning. Our CalPERS team is reviewing the post-meeting survey and early results, indicating a strong interest in a more regular convening of our clinical teams to drive mutual initiatives forward. I want to let you, our employers, and members know that this year's open enrollment will be held September 15th through October 10th. These dates are consistent with prior years. I'd like to announce them in March so the dates can be added to everyone's calendars for planning. The preparation for open enrollment is already underway. We have a number of substantive issues that we're bringing you today, including recommended changes to our value-based insurance design program, the results of open enrollment last fall, and a report out on the first few months of our new PPO. We also look forward to the discussion of federal priorities that will take place tomorrow. Danny Brown will give you a positive update on the status of telehealth access in Medicare, and we'll be happy to talk through some of the new vulnerabilities we're seeing coming out of Washington. That concludes my comments. I'm happy to answer any questions.
Thank you very much. The committee does not have any questions, so we'll now go to the action consent items. Missed, okay. Oh, you moved? Yes. Okay. Thank you. And we have a motion and a second. So all in favor say aye. Aye. Any opposed? Any abstentions? The majority says aye, so the motion passes. Now we go into the information consent item. I don't see anybody holding anything, so we'll accept everything and move into item 6, action agenda items, starting with 6A, Health Benefits Program Proposals for 2026. Rob, I think.
Good morning, Mr. Chair, Mr. Vice Chair, and congratulations again on your election. I look forward to working with you and the committee members this coming year. I'm Rob Derzonbeck, Chief CalPERS team member. This is agenda item 6A, approval of the health benefit program proposals for the 2026 plan year. This is an action item. This agenda item is the second part of the conversation we had last November and focuses on our basic PPO plans. We conducted additional analyses since then, which we'll present to you today. Both potential changes do not impact the HMO health plan premiums for 2026, as these are exclusive to the basic PPO plans. I'll begin by discussing a potential out-of-state basic PPO option. Then I'll hand it over to Dr. Logan and go over modifications to the value-based insurance design, or VBID program, within the PERS Gold Basic Plan. We'll then conclude with next steps. These proposals align with our strategic goal of exceptional healthcare, as they aim to improve healthcare quality, increase equity, expand access, and maintain affordability. Let's now discuss the basic PPO options for out-of-state members. As background, CalPERS offers 12 basic health plans for members. Of the 12 plans, only 2 are available out of state. Those 2 plans are Kaiser Permanente and PERS Platinum. Kaiser's out-of-state basic plan is only available in 7 states outside of California and is more expensive than PERS Platinum. Approximately 96% of all out-of-state basic members are enrolled in the PERS Platinum plan and do not have another health plan choice. Currently, there are about 26,000 basic PERS Platinum members living out of state, and they make up about a quarter of the basic Platinum membership, or 11% of the overall basic PPO population. We've heard from members who are concerned with the lack of basic plan options available out of state. Therefore, our goal was to explore a lower cost plan option for those members living outside of California. We wanted to do so without negatively impacting premiums for the majority of members who are living here in California. Unfortunately, through our extensive analysis, a viable option is not available. Let's go into the details. Together with Blue Shield, we modeled a variety of scenarios, and what we're sharing here are the primary options available to us and the associated impacts. We have 3 options to share with you today. Both options 1 and 2 offer a lower out-of-state premium, but would either cause an additional increase to in-state premiums or would require significant benefit design changes. Our recommendation, option 3, is to maintain the current benefit design and in-state service area. Let's walk through each one. Option 1 would expand the service area of the PERS Gold Basic Plan to the entire country, matching the PERS Platinum service area. We would maintain the current PERS Gold benefit design of 80-20, which means the plan would cover 80% of the cost for applicable services, and the member would be responsible for paying the remaining 20%. The impact to PPO premiums would be an increase of 2 to 3% for both in-state and out-of-state premiums. This additional 2 to 3% premium increase would bring additional stress to the basic PPOs and would make it more difficult to maintain a stable population moving forward. As we all know, The basic PPOs have been experiencing high premium increases for the past several years due to the high cost trend post-pandemic and the premium surcharge in place to rebuild the reserves. As an alternative, we looked at creating a low premium option with significant benefit design changes to minimize the impact to in-state premiums. This is option 2. This scenario would create an all-new, out-of-state PERS Gold basic plan, bringing a lower premium option to members, as premiums would be roughly 30% lower than the current out-of-state PERS Platinum premium. This option would have minimal impacts to the in-state PPO premiums. However, significant benefit design changes would be needed to lower the monthly premium, and these changes would increase member out-of-pocket costs. First, the in-network coinsurance would increase from 20% to 35%, meaning instead of having an 80-20 plan, it would be a 65-35 split, with the plan covering 65% and the member responsible for the remaining 35%. Next, the deductible would also need to increase from $1,000 for an individual to $5,500, increasing by 5.5 times. The maximum copay would also more than double by going from $3,000 to $8,300. Finally, the out-of-network coinsurance a member is responsible for would increase from 40% to 50%. These changes would significantly increase member out-of-pocket costs and effectively create a high-deductible health plan, which research has shown to worsen clinical quality outcomes for members. This is because members forego the care they need, resulting in worse outcomes for them and at times at even higher cost had the conditions been treated earlier. This brings us to our recommendation, which is to maintain the current service area and plan design of PERS Gold. We understand this doesn't create a new offering for our out-of-state basic members to choose. However, given the severity of the benefit design changes in particular, we don't believe there's a viable option to offer an out-of-state PERS Gold plan without having an adverse impact on the premiums of in-state PPO members. I'll now turn it over to Dr. Logan to discuss our proposed modifications to the value-based insurance design.
Thank you, Rob. Good morning, Julia Logan, CalPERS team member. Before I describe our current program for VBID, I wanted to provide a bit of context. Value-based insurance design is a model that seeks to improve quality and affordability by lowering out-of-pocket costs for high-value services. Using evidence-based approaches, value-based insurance design, or VBID as it's commonly referred to, encourages members to take an active role in their health and to make informed decisions about their care. This is often accomplished by aligning patients' out-of-pocket costs, such as co-payments, with the value of health services. By reducing out-of-pocket costs for high-value, medically necessary treatments, CalPERS can achieve improved health outcomes for our members over the long term and potentially reduce healthcare expenses for both our members and our program. Over the last 25 years, there have been variations on the VBID concept. Some health plans and private purchasers focus solely on chronic disease conditions, such as diabetes, and offer reduced cost sharing at the point of service. For example, lower copays for office visits, medications, and diabetes supplies. VBID was first introduced by CalPERS for the basic PPO Gold Plan in 2019. The Pension and Health Benefits Committee considered a broad array of design options, with input from national experts to inform the decision. We considered the opportunity for member engagement and potential savings in the form of both member out-of-pocket expenses and the overall premium impact. The intent was to introduce incentives for both preventive care and support people with chronic conditions. So let's go ahead and review our current program. In brief, the value-based insurance design program has 3 components. The first component represents a series of credits to offset the $500 inpatient care deductible. The second component reduces doctor's office copayments for primary care to $10. The third component waives the coinsurance for maternity care at preferred hospitals when a member engages in the maternity program. We'll discuss each of these components in a little more detail. First, the credits. CalPERS PPO Gold members can receive a credit of up to $500 to offset the deductible per member. A member receives a $100 deductible credit for each of the following activities: biometric or preventive screening, flu shots, self-attestation of non-smoking status or participation in smoking cessation efforts. Members automatically receive credit for second opinion services for an elective surgery. Last, members receive an automatic $100 credit for participation in chronic disease programs. A member will lose this $100 credit only if they decline to engage with Included Health in these programs. As part of CalPERS' strategy to promote the use of primary care services, the primary care co-payment of $10 applies to any visits with the member's matched PCP and also for Included Health virtual primary care visits. As we all know, a strong primary care relationship is important for coordinating all of a member's care, as the PCP acts as a patient's quarterback to direct the care team and recommend strategies for a member to optimize their health. Primary care is the essential anchor for our goals for better health outcomes and affordability. Through Included Health, we offer a maternity program that offers education, support, and guidance throughout pregnancy and the postpartum period, with access to a team of healthcare professionals. Included Health can help members find top OBGYNs as well as explore CalPERS' new benefit for doula coverage. Members save money by getting the coinsurance portion of the hospital claim by enrolling in the maternity care program and using a preferred provider inpatient hospital for childbirth. As we look ahead to 2026, we know there are aspects of our current VBID structure that needed reassessment, which I'll address shortly. We would also like to leverage the VBID program to increase alignment with the CalPERS Quality Alignment Measure Set, commonly referred to QAMs. With our new PPO contract, we have aligned with the quality measures and financial incentives already in place in the HMO contracts. Our goal with these substantial guarantees around quality is to have CalPERS PPOs be as quality and equity centered as our HMOs, so that we have the same high quality and equity standards for all our CalPERS basic members, regardless of whether they are in an HMO or PPO. As you know, QAMs focus on prevention, chronic disease, and behavioral health, and includes measures such as blood pressure control, colorectal cancer screening, and childhood immunizations, diabetes control, and depression screening. Beyond QAMs, we also want to keep the high-impact elements of the current VBID structure, like engagement, the use of second opinion services for elective surgeries, and preventive care. We also considered the areas where our current VBID program doesn't necessarily meet the needs of our members, and areas where we feel we could have a greater impact. For example, only 2% of our CalPERS members smoke, well below the California statewide average, which in turn is much lower than the national average. So it makes sense for us to focus our incentives where there is more need and room for improvement. We also want to build on engagement opportunities across the PPO Gold membership to align with QAMs, and we'll be recommending a mental health component to the VBID options. Next slide, please. With all this in mind, we have been examining ways to improve our VBID program. In addition to meeting with subject matter experts nationally, we obtained input from Blue Shield and Included Health. Blue Shield has experience operating a value-based benefit program for people with chronic conditions since 2017. We propose to maintain the overall structure of the VBID program, beginning with the $10 office copayment for primary care. Participation in the maternity program will be tailored to Included Health's offerings and designed to encourage engagement early in pregnancy to optimize overall health and well-being. Where we propose changes are in the potential to earn credits. The proposed 2026 VBID design will include an expanded set of activities to earn a potential of 5 $100 credits to offset the deductible. The credits are organized into 3 types of activities: including engagement and self-care, mental health monitoring through completion of screenings, and preventive care that include cancer screenings, metabolic health, the flu vaccine, and other adult vaccines. We are partnering with Included Health to promote proactive engagement in care management and the use of expert medical opinion services for an elective surgery. Included Health will reach out to members identified as having high-risk medical issues or who are newly diagnosed. Active engagement with Included Health's care coordinators will be required to earn credits in these two categories. A third and new engagement category involves participating in the Blue Shield Diabetes Prevention Program. Finally, the number of credits that can be earned for completion of preventive care activities will be increased to 4. That is, instead of earning a single credit of $100 for completion of a preventive screening, a member can earn up to 4 credits, totaling $400 for any combination of preventive care activities. Collectively, there will be a menu of options for PPO Gold members to achieve the VBID goals. This means that no matter where a member is in their healthcare journey, they can engage in any number of activities to earn each $100 credit. CalPERS will continue to explore the costs, savings, and long-term implications of VBID strategy refinements for 2027 and beyond. Examples of refinements that are under consideration include introducing some VBID elements into the Platinum Plan. The Gold Plan has been where we have traditionally piloted new benefit components. Now that we have a multi-year track record in understanding member engagement in VBID, we can now begin to consider what options may be appropriate for our Platinum members. We also hope to continue to align with the quality alignment measure set. We will learn from the inclusion of depression and anxiety screening in 2026. We're also exploring a more targeted approach to focus on high-quality chronic disease management for specific conditions that have a high level of prevalence in the CalPERS population. These include hypertension, diabetes, and depression, and are very much aligned with the QAMs as well. Targeting these specific conditions would improve chronic care management in the near term, while also offering the potential of longer-term cost savings. Finally, we're exploring lowering cost sharing for doctor visits for certain chronic conditions. Such a model has more complex financial implications for the overall CalPERS basic PPO plan because of copay changes, and there is a distinct possibility of member migration between our Gold and Platinum plans. Any changes to VBID for 2027 we will bring forward for your approval next fall. For 2026, we ask for you to approve our modifications to the VBID credits. We believe that these recommendations to update the VBID program for PPO Gold members in 2026 provide the right balance between expansion, alignment with QAMs, and maintaining premium neutrality. I will now pass it to Rob for next steps.
Thank you, Dr. Logan. So for next steps, if the committee approves the modifications to the VBID program, we will then prepare the necessary implementation activities. For the proposals already approved last November, we will communicate the plan expansion to members in advance of and during open enrollment. This concludes our presentation, and we're happy to take any questions.
Thank you. So we do have questions from the committee. We'll start with President Teresa Taylor.
Actually, my question as I turned to the next steps was, can we break out the do not approve new OOS plan option for 2026 from the rest of this so that we can vote on it separately?
If that's, yes, we can do that.
Okay.
So we should still start with discussion on the board, on the committee, and then we have people on the phone who want to give the public comment. So do you still want to continue talking?
Oh, yeah.
Okay.
Sorry, I accidentally turned it off.
I will get.
There we go.
Okay,
Sorry
you're
about
back
that. I like the our new VBID plan. I appreciate you guys' work on this. I did not know our I mean, I think it's different that we're doing the engagement, mental health, and cancer and other screenings. So I thought that was a really kind of inventive program. So I congratulate you on that. But I would like to talk about our OOS plan for our out-of-state members. We have SEIU has out-of-state employees. There are not very many of them. However, they pay a significant amount more than our in-state employees on their health care. So while I understand that this would actually be voting in for all our out-of-state members, I think it's important that we consider our out-of-state employees who work for the state of California, but do not get treated like they work for the state of California when it comes to health care. So that's all I wanted to say for my co-board members. Thank you very much.
Thank you, President Taylor. Now next speaking list is Trustee Yvonne Walker, please.
Just to be clear, are we going to discuss the out-of-state plan separately? If so, I can wait until after we vote on everything else.
If that's, we're talking about both, we are voting separately. So why don't we, if nobody has any comments on the improvement and on the value-based insurance design, we can move to the out-of-state. Is that okay? So I will entertain a motion on the staff recommendation.
Second.
Trustee Jose Luis Pacheco, and second is, do we have a
It
second?
was Teresa.
Teresa, thank you.
Are we voting to separate them?
Yes.
what we're doing?
No, we already
Oh, okay.
agreed to separate them,
You're just doing it on your own. Okay, my
but
bad.
we didn't have any unless there's more discussion from the
There is.
committee members on the value-based insurance design. We can vote on that one first, and then we can go to have discussion on the out-of-state plan.
Okay.
Okay.
Okay, so then I can second that, yeah.
To be clear, the motion is to approve the staff recommendation.
Yes, the motion is only for the value-based insurance design.
Got it.
So the motion is approve the staff recommendation for the value-based insurance design, which basically improves quality care, quality, encourage case management, preventive care. Okay? Okay, that's the motion. It's been second. So all those in favor say aye.
Aye.
Any opposed? Any abstentions? So the majority is A, so we have, the motion passes on the staff recommendation on the value-based insurance design for 2026 for the PERS Gold. Okay, now we'll move into the discussion on the out-of-state plan, PPO plan option.
Okay, so now I can talk?
And we will start with Trustee Ortega.
No, I think we started with
I've been waiting.
Oh, okay, I'm sorry. Sorry, you were on it.
Yeah, I'm
Miss-
still on.
Please continue.
Okay, thank you. So I do understand the recommendations you made, the recommendation you made around the out-of-state plan option for 2026. But I just will say, but I will just scooch over a little. But I will just say that it is still a concern, and I want to know how we're going to move forward, because I hear about this a lot from out-of-state retirees. I do understand the recommendation today, but I would also like a roadmap of how we're going and where we're going to get to.
If it's okay, I'll take that, Ms. Walker.
Sure, anybody can
Thanks.
answer me
Yeah.
that knows.
So to your point, we just did a run in our own data to update these numbers, so we believe them to be the most recent available. But there should be, I think, 258 active state of California employees who are working in other states. So they
That I understand.
yes. So it is a small number. But the impact that is felt by the lack of availability of a more affordable option is profound. So last year in bargaining, I believe, and Ms. Ortega, you can jump in and correct me if I butcher any of this, but there were two healthcare supplements, additional payments that were authorized. One was a $165 supplement to all state of California employees.
It's only SEIU.
SEIU, bargained employees, thank you. The other one was a supplement, especially for this group of 258 people that we're talking about. And that was it is a $200 additional monthly payment for individuals, a $250 payment for couples, for two folks, and then a $300 payment for families.
I saw this.
So the difference between the premiums in platinum and gold for the singles are covered, as I understand it, by the combined two additional payments. They do not make up for the difference for couples, and the effect is particularly acute for families. So the delta for families is close to $1,000 a month, and this is $465. So there is still a delta to be had. I think in our recent count, it was about 60 families that were affected by this. Is that right? Approximately 60 families. So the cost of doing this is, as Rob mentioned, that if we were to do this for all of the PERS Gold enrollees, the changes that would be necessary to happen amount to a difference of 2 to 3%. That's $50 to $75 million that would be borne almost entirely by our existing members. The impact, the cost of doing this for this smaller group, effectively of families living out of state, is a much smaller number. So our hope is that would be something that could be addressed specifically for them. We looked at a lot of other options, including the possibility of establishing a plan exclusively for these members. That is not allowed by the enabling statute at CalPERS, the PEMCA statute. So we are expressly prohibited from creating plans that are only available to a subset of our members. So our hope is that this is something that could be worked through, obviously at a much lower price point for these specific members. That is typically done through bargaining.
Right. So just a finer point on what I think I'm asking. So how does this impact our retirees out of state under 65? And then just in general, because out-of-state healthcare costs are, it has a significant impact on folks, especially on retirees who are on a fixed income, right? And so how does this impact, and what, if anything, are we going to do to, can we do? Or, what is, again, our roadmap to, looking at addressing, because it's not just active members, right? And I recognize and understand, what happens with the actives, was involved with that for a while, but does not address the retirees, who I hear from a lot about the high costs that they have as they live out of state.
Obviously that is a challenge. Our bargaining power in the other 49 states is not commensurate to our bargaining power in California, where the vast majority of our members live. We try to leverage everything we can to keep those costs as low as possible, but they are high. The reason that I called out the active members who because of their job, are required to live out of state is because they do not, there's no flexibility there. There is more flexibility, this is not what anybody wants to hear, but there's more flexibility for retirees who are not there for work reasons. Not where we want to be. We are going to continue looking at alternatives, but the ones that we explored over the course of the last many months were prohibitively expensive for the rest of our members. And I will add, adding those costs at a time when we've already also added a surcharge is not only a lot to put on our members in terms of additional costs, but we believe could also affect the stability and ultimately viability of the PPO plan. So that is what went into our recommendation not to do that at this time.
Oh, yeah. None, and I do understand the recommendation. I still think it is worthwhile. I don't know, I don't have a solution to recommend to you. If it's like a work group with, we can't be the only state that have people living out of state. And so is there a work group to try to come up with some kind of solution or possible solution? I don't know, but
Yeah.
I just think that it's not enough just to say it's challenging without trying to figure out something else.
Yeah, understood, and we're not going to give up. We actually have talked to the states, to both trust funds in these other states and CalPERS equivalents in some of these other states like New York and Illinois, and to see if we could, for instance, piggyback on their networks, which we already do to some degree, but not in an official way. So the challenges there is that among other challenges is that it would require statute in those states to do that. So and really with our numbers, not much in it for them. So they have not been inclined to go there. They are some of those states are complicated places.
Some of them.
And that's not meant to be pejorative. It's just meant to be realistic. We're quite complicated ourselves.
Right.
But we have explored those options. We are going to continue pursuing this until we find a better solution. But right now, we're not there.
I appreciate that. Thank you.
Thank you.
Just, I have a couple questions, but I do want to say the out-of-state subsidy was negotiated in 2023, so it's been in place since 23. Do we know if there are any active employees from other employers working out of state? Is the state of California the only one of our employers who has active out of state?
So when we do a data pull through my CalPERS and look at this, we do see there are a number of active state employees who are residing out of state, but this is where we do not have enough insight into why that person is there, if they were approved for out-of-state telework assignment, or if they are running out vacation before they actually retire. And so there are more, but as far as like active, we don't see that. We're looking at enrolled lives when we look at this.
Yeah, slightly different question. So like a county or
Oh,
a city, do
absolutely.
we have
They're
other out-of-state actives from other employers?
There are out-of-state public agency and school members who are living in mostly in the states surrounding California.
Okay.
And so that's where we see the majority of the public agency members. And then those members can use either their work address or home address to have other eligibility. And so this is where they could still use the work address inside California to be enrolled through healthcare, but then live across the border. Sorry about that.
Yeah, and we should clarify that those folks were not included in the count that we just shared because for exactly the reason Rob mentioned, they have the ability to use the networks that are along the border.
Right, okay, thank you. And then, Dawn, my other question is about the PEMCA limitation that you mentioned. So, if the statutory prohibition wasn't there, is it a viable thing to even research or consider that if there was a statutory authority to create a plan for a subset of employees or a subset of members, is that something the market would would it make sense to even pursue that? Because, I mean, a statutory barrier is something that can be overcome, right?
Yeah, that's a good question. We hit our limit on the statutory barrier. We
Yeah.
didn't creating a health plan for 260 people would certainly have its challenges, and the question would be whether you could build something that that was more cost effective than what we have under Platinum is an open question. We know that the Kaiser plan is higher cost than Platinum, so that's not a good sign, but it's something that we could explore further if that is something that the board is interested in having us do.
Okay, thank you.
Thank you. Now we go to Vice Chair Kevin Pockey, please.
Thank you. Thank you for the presentation. Unfortunately, health benefits is never the easiest conversation. Just for clarification, and please stop me if I am out of line. There was an article by the U.S. government accountability about health insurance costs are increasing. The projected increase is much more than the 2 and 3% on our slide. Is the 2%, like, if we chose option one, would the 2% be sort of compounded on top of that
Yes,
possible?
it would be in addition to whatever the trend is for going into next year.
Okay. And then option two, the significantly increased member deductible maximum copays. How does that differ from the already Platinum plan?
So it's significantly more member out-of-pocket cost. So the Platinum plan right now pays 90% for the applicable services. So taking up the share of the cost, the member is responsible for the 10% remaining portion. This would go to a 65-35 split. So the plan would only pay for 65% of it, meaning the member would have to pay for that 35%. So much, much more significant out-of-pocket cost for the member.
So if a member had to choose between the option two gold versus the Platinum, they're better off taking the Platinum plan.
So they're better off taking the Platinum plan if they are regularly seeking services. If they're not regularly seeking services and just are only looking for a lower monthly premium, then the option 2 gold would be better for that person. However, we have seen, and with high deductible health plans, members who have such high deductibles often forego care. So even though they think they're healthy and they think they're doing all the right stuff, they're actually not seeing their physicians as they should when smaller things come up, and they turn into larger, more worse outcomes for the members. So that's a definite drawback, and one of the reasons why we don't offer a high deductible health plan here, because it's not in the best interest of the member.
Thank you. That's all my questions.
Thank you. Next, we'll have Trustee Jose Luis Pacheco.
Yes, thank you, Rob, for your presentation. I want to ask you a question about the 11% of the basic PPO members that live out of state. What is that number? In that 11%? What does it equate to numerically? Is it
So it's 26,000 members.
26,000, and then the rest of the remaining members, 89. The
89% there are here in California.
Are in California, then. And in option one, you said that it would be a 2 to 3% increase on top of the trend. Is that moving forward for just 1 year, or is it going to be, or how is that going to play out?
That would be, depending on the migration for the first year, it would be between 2 and 3%. But if more migration happens over future years, it could then also grow. That could grow beyond, just a little bit beyond the 3%. But it should cap at about 3% or a little bit, 3.1%.
If there is projected migration, then we would have the number would increase then.
Correct. But it would increase to only 3% is the high end. 3 or 3.1% is the high end if everybody from platinum went over into gold.
If everyone everyone.
Correct.
Okay, and that would be, do you foresee that kind of scenario? I'm just.
So that's potential because we haven't offered this previously, and so that's where this range is a realistic range on if those members do just all want to switch over to PERS Gold, because PERS Gold is still an 80-20 plan it covers a lot of the portion for the costs. So there could be a lot of migration that happens because of this.
But we're not sure until.
So we're not sure, but if everyone transitioned over, it would be a 3% increase to the PPO rates, and as Don mentioned, it'd be $75 million for the entire program to have to increase that way.
And how would that affect our reserves at this time?
So it would impact the reserves negatively because we would probably see loss of membership in California. So the 89% who are here in California, they would likely choose another health plan option. And so the kind of making this situation worse of having a more unstable PPO population. So the fewer lives we have in the PPOs, then it would make it harder to recoup the reserves. Our costs would go up because we would likely retain the sicker members in the PPOs.
So it'd be a spiral. It'd be a kind of a spiral.
It would create some instability.
Instability. Okay. Thank you very much for your comment. I appreciate that, sir. That's all I have. Thank you.
Thank you. No more comments, so now we'll go to public comment. We have 16 people on the phone, so we could. 25. Okay, we could start with public comment, please.
Okay, great. Chairman Rubalcaba, we have Matthew Lyman on the line.
Please proceed.
Good morning. My name is Matt Lyman, and I'm a state employee of Chicago out-of-state office, actually. I've been an employee for California for 11 years. And I have to say my premiums have gone up by double digits the past 4 years. So my coworkers actually pay almost a quarter of their entire paycheck on these premiums. So I think it's rather ridiculous, actually, that we're just going to sacrifice the out-of-state people just to please a couple thousand of in-state people. I think that the more fair option is for everybody to just take a minor premium increase so that we're not just sacrificing a whole segment of people who work for the state. And I'd like to remind everybody in the meeting today that the 258 people who live out of state bring in several $100 million of tax and fee revenue for the state of California. Okay, so while we may not be in the thousands, we are still significant. And that's all I have to say about that. Thank you.
Thank you. Can we have the next speaker, please?
Yes, next, Mr. Chair, is Mary McLean. She's on the line to speak to item 6A.
Hello, this is Mary McLean. I'm a spouse of an employee, and like other out-of-state employees and families, we feel that the out-of-state should be treated the same as in-state employees based on, with affordability of benefits. We pay over $1,200 a month out of pocket, and it does affect our income, our monthly amount, and I feel like there has to be something that can be done, whether it is even providing additional, like a credit to the out-of-state employees. If you don't want to, mess with the benefits for the whole state, maybe there's something you can do to give back to some of those employees to help us with our, dealing with day to day. I mean, groceries are insane, everything, I think that you guys should do more for your employees. Thank you.
Thank you, Mary. Next speaker, please.
Next, we have Jacqueline Mayo Bean to comment on item 6A.
Hi, my name is Jacqueline Mayo Bean, and I'm a single mother, and I've been an office technician in the out-of-state Chicago office for CDTFA for the past 15 years. I currently have PERS Platinum as an only insurance option. Up until December of 2024, I was paying insurance for myself and my now 26-year-old daughter. These insurance premiums, deductibles, and copays have been brutal, a literal yoke upon my neck. Without going into every detail of my financial life, I just want to express gratitude for the possibility of being able to add $361 additional dollars of my pay to my household monthly budget, being a total of $4,336 a year. Due to inflation, rent, utilities, gas, groceries, high insurance premiums, both medical and auto, my bills are astronomical. I have been living off of my credit cards for the past 4 years. Needless to say, after using every cent of my paycheck every month to pay my bills, by the 7th of the month, I am cash poor. I have to take out cash advances or pay by credit card any remaining bills that will allow me to do so. I am one of the working poor, without a doubt. Please, for the love of God, vote so that we can share in the equity by expanding and extending PERS Gold to all out-of-state employees. Thank you for your time and for your much-needed vote.
Thank you, Jacqueline. Next speaker, please.
Next, we have Delone Johnson. Go ahead, Delone.
Sound very familiar to myself. I'd like to comment in favor of the out-of-state on 6A. I'm an out-of-state employee. I've worked for the state for 16 years in the Sales and Use Tax Division for the BOE and CDTFA. I had PERS Gold before, or comparable, which was PERS Choice, before it was taken away in 22. I did not witness any strategies to reduce the drastic increase in my premiums when we lost PERS Choice. 2 to 3% was nowhere near the increase I suffered to go to PERS Platinum. There is a 600% difference in PERS Platinum versus PERS Gold for me. It makes me uneasy when there's no action recommendation on the agenda before us to save out-of-state employees 600% of their health care premiums. My premium is over $1,000 a month. It's been that way for 3 years, and we've sort of been stuck with it. We're on this call now for a decision that happened in 2022. So to me, it seems like not much is being done about it. I would think that CalPERS would have more connections with lobbying the state during bargaining or some other process, since the way the board is designed, it gives them direct access to this information. The adjustment, if we are moved out of state to or have the ability for a second option of 2 to 3%, it was stated that that would be too large of a increase. I think it was somewhere in the 50 or 60 million, or maybe even higher, that they said the total cost would be. But on a per capita basis, which is what it should be looked at, it's very palatable. Again, I never had a 2 or 3% increase in my health care. The more I pay in premiums, the more the state pays. So it would behoove them and CalPERS to kind of work with the state to figure out some way to offer us more stipends to bring this down. It was also noted that we do receive stipends. One of them is taxed. We receive 2. The 165 is not, but I receive a $300 stipend that's taxed, so it's more like 200. So we're not even getting the full benefit of these supposed stipends. And one of the biggest problems with the stipend is that's considered earned income, the $300 one I receive. So if I would have normally been eligible for some kind of, let's say, student loan, I could potentially be knocked out of that because of the increase in the stipend that I receive for health care. And that's already supposed to be earmarked elsewhere.
Mr. Johnson, could you please
Yes.
try to sum it up? You only have 3 minutes.
So I would urge a yes vote in this matter. Thank you.
Thank you. Next speaker, please.
Next, we have Carrie Duty.
Hi, my name is Carrie Duty. I'm still trying to get over just what I've been listening to for the past 30, 45 minutes during this presentation, because basically all I heard coming out of it is, we're small, we're insignificant, who cares? Really the question, and I can't remember, I appreciate the person that mentioned it, is that we're state employees for California, but not being treated like one. Option 3 in that presentation was just offensive, and I'm flat out angry. I can sit here and tell you how this impacts my family, but honestly, I'm almost even questioning if that even matters at all, if option 3 is the one that's being selected. And I just, for the 16 years of service I put in for the state of California, just being treated like a non-California employee, it's just, it makes me incredibly sad, near depressed with how my 16 years of service is really being considered. And I really do hope that there are some hearts out there that will consider option 1 for us, because even though we make up these little small numbers, these small numbers that I keep hearing, we're still people. We're there helping California. Good chunk of us has been working for the state of California for so long. But we're small. Why should our feelings be considered? And that is just blatant offensive to all of us, the 26,000 of us that work out of state. Thanks.
Next is Candace Steinbeck.
Hi, my
Go
name
ahead,
is Candace Hi, my name is Candace Steinbach. I am a state employee that works out of the Chicago office. I have worked for the state for over 16 years. I currently pay $1,200 for my family to have health care insurance with no other options being offered. It would greatly benefit my family to be able to have the Go plan extended to us in option 1, not some option 2 that's not going to help me switch or lower my healthcare costs anyway. We could have saved over 12 grand this year if we were able to switch to the Gold plan. Prior to 22, I was enrolled in PERS Choice that had the same 80% co-insurance option that PERS Gold has today. While yes, this may increase premiums for in-state members 2 to 3%, the cost of that on an individual is what, $10, $20, not $1,000 more that I'm paying, even with the supplements. They're not even coming close to making up or making us equitable to our counterparts that live in the state. So I urge you to take this opportunity to bring equity and affordability back to our healthcare and out of state, and vote for option 1, please. Thank you.
Thank you.
Okay, next we have David Aguinaldo.
Hello. Hello, everybody. Good
Yes, go ahead.
morning. My name is David Aguinaldo. Sorry? Hello?
Go ahead.
Okay. Good morning, everyone. My name is David Aguinaldo, and you all may recognize my voice from making public comment over the last several years of board meetings. I have been an employee of the state of California for almost 15 years and have consistently been covered by CalPERS health insurance plans. While I appreciate the work that has been done by CalPERS staff, I am disappointed that no one reached out to myself or any representatives from out-of-state offices while planning on these new options. I found out about this vote on Monday, March 10th, when I received an email from my CalPERS board meeting subscription. This led out-of-state workers to only have 1 week to try to understand the options, request more details, to organize each other to make sure that our voices are heard. And I don't believe that that's acceptable. If you're working on a plan that is supposed to be for people in out-of-state, you need to include out-of-state voices. Until 2022, I chose to subscribe to the PERS Choice plan, which was an 80% co-insurance plan. Earlier, I heard that there was no 80% plan that had been offered in the past to see how many people would have been on the 80% plan versus a 90% plan, but that is not true. Prior to 2022, almost everyone in out-of-state was part of the 80% PERS Choice plan. When the beginning in 2022 with the introduction of PERS Gold and PERS Platinum, I saw my rates beginning to increase. The last premium I paid for PERS Choice was $482.56 per month, and today I am paying $888 per month out of my paycheck for PERS Platinum. As I've been stating over the last few years, this has not been sustainable and continues to be unsustainable. You have an opportunity today to extend coverage of PERS Gold to out-of-state employees. I do not see this as an expansion of benefits, but rather a restoration of a benefit that we had previous access to prior to 2022. We do not want to continue to be exploited to keep rates down for any plan, including the PERS Platinum plan. This is not our responsibility, and we have become poorer due to those decisions. Please help us to achieve the equitable and affordable care that we deserved per the CalPERS' own strategic goals that you presented in your slide presentation. Thank you.
Thank you. Next.
Next, we have Judicus Espinal Sanchez.
Hello? Hi. Hello?
Yes, please proceed.
Hello, can you hear me? Okay, hi. Ms. Judicus Espinal Sanchez. I've been with the state for 28 years out of the New York office. Prior to 2022, I still think I never had a choice. I was involved in PERS Choice. I would think that probably was in 2008 when we were told we could no longer have an HMO. I always had an HMO because I like the fact that I didn't have to worry about when going to the doctor, I had another bill coming in the mail. But unfortunately, after that, I was told, oh, don't worry, it'll be covered. The state is going to give supplements. You'll be okay. I have a family, and I pay $1,200 a month. And not to mention that we also pay almost close to $400 for another insurance that we don't know if we're going to be able to take advantage or not. So that's about $1,700, $1,600 a month just on insurance alone. Not to mention all the other insurance we got to pay. So, like everyone said, we are insurance poor, and it'll be nice if you guys can consider option one and give us a choice to have something that we can afford our groceries in our daily life. So please give us a choice. Don't continue and provide us lack of choices. This will save me over $12,000 a year. So again, I urge you guys to vote one. Thank you.
Next is Jonathan Rudnick.
Rudnick. Good afternoon. My name is Jonathan Rudnick. I've been with the state of California in the Chicago office for 17 years. I have raised 3 children so far during this time, and I know you guys said that your concern with us switching to the gold plan is a concern that people would not seek out the necessary medical, looking at their just general day-to-day medical concerns. But I can tell you that is not true as a father that has raised a child with autism. I did not ever hold back from our son needing any care or special need help. That was the coverage through the PERS Choice program more than covered it. We were able to use the savings and the premiums to pay for the higher deductible when we needed to for our 3 children being born, and also with our son being in special care for his needs. So to say that we won't seek out any kind of needs because of that is not true. Any person can make that decision of their own, but that's something that we should be allowed to, as grown adults, consider. But being able to have a cheaper option for our day-to-day lives should be something that we should be allowed to as state of California employees. So I would just urge you all to consider giving us the option, which we used to have under the PERS Care, PERS Choice, and PERS Select options. Give us that opportunity to look for and make our own decisions on what we would like to do as adults. So I would just ask that you guys consider allowing us to have this opportunity. Thank you.
Okay, next is Camille Hardy.
My name is Tennille. Hello, my name is Tennille Hardy. I'm a franchise tax board employee working in the Chicago office. I have been an employee of the state of California for almost 16 years. I am currently on a family plan that is about $1,200. And as Delon said earlier, even with the stipends we receive, we still pay almost $900 a month for health insurance. This disparity is a huge burden on me and my family. I have a son that just graduated from college that I'm paying for, a daughter that is in college that I'm paying for, and I have another one starting next year for college that I will have to pay for. Apparently, the world and this board thinks we are rich. I am here to tell you we are not. I appreciate my job very much, but I would also like to feel appreciated by my job. I don't even understand why we have to be here fighting for basic rights like affordable health care. You guys set goals and considerations for 2026 to make sure there is no disparity between CalPERS members that are HMO versus PPO. But what about us? What about the disparities between state employees that are on the differing PPO plans? Why are our goals and considerations so far down the road? You all have the power to change the lives of so many people. Please, please do so. Again, please take this opportunity to bring equity and affordability back to our healthcare options and allow for the expansion of PERS Gold to out-of-state employees. Thank you all for your time and consideration.
Thank you. Next is Tara Jones.
Hi, my name is Sarah Jones. I'm a state employee working in the Chicago out-of-state office. I've been an employee for California, serving it for 1 year. I wanted to point out there's a few things I noticed y'all are saying. I would prefer option 1 where we get the choice, but I think some of your core assumptions are not entirely accurate because, speaking only for myself, I would probably stick with the platinum plan even if the gold was an option just because I'm clumsy and paranoid. So I don't think there's any guarantee that everyone would switch to the gold. I will also say that I understand we have a need to look out what's for the best interest of the state as a whole. And while we are a subset, understand if you make a habit of treating people in these offices in a way that is perceived as unfair, you may have trouble staffing them. I would also point out, I thought there was something curious about this, that the statute does not allow the creation of plans for only a subset of the employees, and yet you've already done so. In this case, there is already a plan only for a subset of employees because the in-state employees are a subset of all state employees. So if only in-state employees can get this gold plan, then that is a plan that is only for in-state employees. I'm also a little puzzled why increasing the overall risk pool increases the premiums under option one. So I'm a little confused about that. That doesn't seem to make a whole lot of sense to me. But I've not done the research. But I understand you want to work with us in the best interest of the state as a whole. I won't tell you anything has gone particularly bad for me, but I believe it's in the best interest of the state as a whole to have a perceived level of fairness with the employees so that they can properly serve you. Thank you.
Next, we have Shelley Owasanyi.
Hello. First of all, I want to thank you for taking the time to listen to state employees affected by the question of whether to expand PERS goals to out-of-state workers. My name is Shelley Owasanyi. I work for the Franchise Tax Board in the Chicago office for the past 16 years, helping bring in millions of dollars in tax revenue for the state. In 2022, PERS choice was taken and we were forced on the PERS Platinum. This caused a great financial burden to be put on out-of-state employees. It effectively was a huge pay cut. My costs have increased over $500 a month since 2021. As I just said, a family of three, a working family of three, pays $1,200 as a payroll deduction. A two-person family like my own, my payroll deduction is $890. This means most of us spend more money on our healthcare premiums than we do our mortgage. We spend more on premiums than our pension. It is the largest deduction from my paycheck. Our current plan is just unaffordable. PERS goal could reduce our costs by 85% or more. It could bring my cost from $890 to $110. For a family of three or more, it could go from over $1,200 to less than $200. These savings mean people could afford daycare, car payments, just quality of life costs that right now are really hard to afford. I understand the concern of increasing premiums, but the current system unfairly punishes out-of-state workers with these exorbitant costs, often 10 times more than in-state costs. A 3% increase for a PERS Gold member would mean up to $6 a month, but it would save me $700 a month, and it would save families $1,000. It also harms our ability to retain people. People begin their careers at the Franchise Tax Board in Chicago, only to find out their take-home pay is $5,000 to $10,000 less than they thought it would be. That's a huge deterrent to for people to make FTD their long-term career. We're just asking for an affordable option. Please vote to add PERS Gold as a healthcare option for out-of-state employees. I know the recommendation is to do nothing, but I want you to know the current situation hurts people who have dedicated their careers to serving California. I cannot overstate how much we need an affordable option. Thank you for your time.
Next is Newton Casanato. Go ahead, Newton. Please proceed.
Hello?
Yes, go ahead.
The network is quite bad, but if you can hear me, I can go ahead. Yeah,
I'm sorry?
my name is Newton.
He wants to know whether he can be heard in the auditorium.
Yes, you can.
The network is quite bad here. I can't hear anything from your end.
We can hear you.
You can skip me and call me back maybe after another person or another one.
Okay. Yes. The next caller, Steve Nielsen, go ahead.
Hello. Hello.
Yes, please proceed.
Hello. Thank you to the board for taking my personal statement. I just want to echo what some other people have said, that the vast majority of the 285 out-of-state employees are responsible for collecting revenue for the state that supports essential public services. Our current healthcare options are prohibitive in cost, and I just want to ask that you continue to look for ways to find us an affordable and equitable healthcare option. And I also want to say that I'm not interested in a high deductible health plan. Thank you.
Next, we have Dennis Barch. Go ahead, Dennis.
Yes, good afternoon. My name is Dennis Barch. I've been with the State of California Board of Equalization, CDTFA, for approximately 40 years. I have seen many healthcare programs come and go, starting with Blue Cross Blue Shield that I first started back in 1985, which we then went to at HMO back in roughly 2000 and about 2000, actually I think it was 1999, to then to various PERS options, PERS Care, PERS Plus, PERS Choice, but in actuality, there is no choice. What we're given today is PERS Platinum. So I don't understand why we can never have an option. We do the same work as our in-state counterparts. We're not represented. We're the minority. And it's wrong. It's totally wrong. Many hardworking people here in the East Coast. I'm from New York. Obviously, we have people in Chicago, Houston, also Sacramento, and there are also some people within rural counties within California that probably do not have enough health care coverage. But my in-state counterparts, they have many options. At one time, they had numerous HMOs that were counting into about 21. We have one. As you've heard numerous times, $1,200 a month, $14,400 a year in premiums that we're paying for. It's quite a lot. Okay? I don't believe any one of you board members, I'm not sure what plans you have, but let's just say this. At the end of the meeting or so, or maybe when you go home tonight, think about the options that you have for you and your family. I've dealt with people that came in our office. One was George Runner, whose wife had been sick. He was a board member. And going back years ago, his wife had numerous problems, and he was thankful for an HMO. We don't have that in New York. They don't have that in Chicago. They don't have that in Houston or anywhere else. And that's not right. I'm sorry. That's not right. Yes, we're different. We live outside the state of California, but we are California employees. The other thing I wanted to mention is retirees. Retirees are paying high premiums as well. I think right now a family plan for retirees is about $795 a month. Going back a number of years, it was zero. If we look into what the people in California, the retirees that have HMOs, what are they paying? Nothing. I'm a future retiree. I'm going to be 63 in July. Bottom line is that I'm looking forward to retirement, but I'm going to have to pay $800 a month. Why? If people in state don't pay anything, why can't we be the same? You have options. You have Kaiser Permanente. Lastly, I want to bring out is that back in 2001, the state of California offered a rural healthcare equity program where they set aside $15 million, and we had to collect our bills and turn them in and hopefully get reimbursed. And if there was more items turned in than money's available, we got a prorated share. I've heard costs by these various people who have spoken. It cost $75 million to do this and to do this and to do that, and to 2% across the board for other people. How about putting a fund together? All right? I will wrap it up. Thank you. Bottom line, put a fund together, say $15, $20 million, that hopefully we'll all stay healthy with all the programs to go to the doctors, and we don't have to go into that. But God forbid we do. At least we have the option to do that. That's all we want is an option. And for 40 years, we haven't gotten one. Thank you much for your time. I hope you finally do something about it. That's okay. Call me back. We'll do it again. Anytime you want. You have my number. Thank you.
Next speaker, please.
Next, we have Newton Casano is back.
That's okay. Call me back. We'll do it again. Anytime you want. You have my number. Thank you.
Next speaker, please.
Newton Casano, you're back on the line. Hello? Go ahead. Okay. We'll go to the next caller. Elizabeth Edwards. Go ahead, please.
Hi, my name is Liz Edwards. I am an out-of-state employee in the Chicago office. I've been with the state for 14 years. Just want to keep it short and sweet. We're begging you to please consider and vote yes for option 1 for the PERS Gold Plan. A lot of people, as you've heard, have shared their heartfelt stories. This is very, very important to all of us. We love working for the state of California and serving all of their citizens. Please do not discount us. Please consider us just as important and as valuable of an employee as the rest of the state of California. So please vote for option 1. Thank you.
Okay, next we have Alba Sanchez. Go ahead.
Hi, good afternoon. Thank you for hearing me out. My name is Alba Sanchez. I've been with the state for almost 33 years. Following what Dennis said and everybody else has echoed in this meeting, you know, these options 2 and 3 are awful, unacceptable. You know, we're being treated almost like the stepchild. You know, it's really unfair where single person pays 0 in California, we pay $361. Family of 2 pays $104, we pay $888, and a family of 3 or more pays $190, we pay $1,208. I'm not sure if any of you board members, you know, have the same premiums we do, but if you have a pay cut of $12,000 a year going to insurance that everybody else in California doesn't, you know, it puts you in a really terrible spot. You know, I didn't choose to be in New York. The state of California opened up an office in New York. They hired us, the same thing that they did in Chicago and they did in Houston. We are your employees. We work for you. We represent you. We do everything by the book exactly the way you guys requested, but you guys do not treat us the same way. It is a hardship. I mean, New York prices are ridiculous. And on top of that, $12,000 extra of insurance money. When we're looking at a 2 or 3% per person, we're talking about a family of just 2 people going from $104 to $107. We're talking about a family going from 190 to going to 197. Is that really a lot? I understand you're looking at the big number, but we're showing you what the individual number is per person. $12,000 extra a year for my family and I. That is very hard to deal with. I've been working 33 years. We did have a whole bunch of other plans. We did have an Addenda HMO in the past. We did have different choices in PERS, PERS Care, PERS Choice, PERS Select, PERS Plus. How do we just get to just PERS Platinum? I am also considering retiring, you know, soon, you know, within the next 5 years or so. I'm looking at the astronomical premiums for retirees, you know, 890 right now for a family, 631 for 2 people, and, you know, 275 if I was single, but you know, obviously I'm not getting rid of my family. So with that being said, you know, it's a detriment. It's a real detriment. So I beg you guys to please vote option 1. We need options. I mean, everybody should be entitled to the same. Before you said, and I know somebody mentioned this, that you can't create a subset for out of state, but you guys have in turn created a subset within California and excluding us from being part of that group. We want to be part of that group. We're not asking for anything different. We're just asking for equal treatment.
Thank you. Can you
Thank
please
you so much.
sum up? Thank you. Next speaker, please.
Okay, thanks. The next speaker is Sterling Johnson. Go ahead, Sterling. You may proceed.
Hi, I'm Sterling Johnson. I've been a tax auditor for 1 year out of the Chicago office. One of the things I saw when I first saw my whole insurance plans options when I first enrolled, I was going to go with the PERS goal because I thought we had choices back then. But later, after a few months, I learned that only premium was our only option. And looking at it, I'm single, so it's not a big detriment to me, but it's like looking forward, want to start a family, and I'm just looking at the big pay cut I'm going to keep taking if I had like more members, just adding to that. So just looking at the future and like want to keep a career here, I'm looking at what I'm going to lose. And I just recently heard about stipends. Like I was not receiving those at first until I had to like talk to some people, and I learned that there's another stipend that I never received at all. So it's just things that's been like a pay cut that I was never really expecting at first when I was like when I first started working here. That's all I got. So my ask is just have us give the choice for option one. It's just not for me, but just everybody who really needs that.
Thank you. Next, we have Joanna Martinez. Go ahead.
Hi, my name is Joanna Martinez, and I'm a state employee working in the Houston out-of-state office. I've been with the CDTFA BOE for 15 years. Previously, I was part of PERS Choice, which is basically the same offering as PERS Gold today. And, you know, I want to reiterate that recruitment and retention is a really big issue, as it is already. And for a new auditor to have to pay 21% of their gross pay for health premiums, when in the past we would have been able to, you know, say that our health plan was really great, the cost was great, you know, in comparison to what's out there in Chicago and Houston and New York, what other employers offer. It's just exacerbated our retention and recruitment issues. Thank you.
Next, we have Fred Simpson. Go ahead, Fred.
Hi, my name is Fred Simpkins. I apologize ahead because my topic is a little off topic, but I'll close with the comment on the topic. I work for Monterey City Transit. I live in Carmel, California. I've been a CalPERS member for 22 years. I sent the board an email explaining this problem. Approximately 2,000 Monterey County CalPERS members have Anthem Blue Cross Aspire HMO insurance, and got a shock earlier this year when we found out they no longer offer access to this provider in Monterey County. And as of March 1st, it was announced the termination of this relationship. I was informed in early March that I will be assigned a new provider in Santa Clara County. The only exception is for people who are currently pregnant, undergoing treatment for serious illnesses like cancer. And there's a lot of people who have to drive an hour or more for healthcare. I was recently informed that my new primary care physician would be located in Gilroy, California, a 1-hour drive from my house. I also was told that I have no access to urgent care providers in my area or to have lab work done also in my area. For us, there are literally no doctors or hospitals available in Monterey County. I was told by Anthem representative that in an emergency I could go to a hospital in my area, but ongoing care would have to be out of county. The only way for me to change plans is to have a death in my family, have birth of a child, or get divorced. One other option is if I move to a new physical location, and none of these options are available for me at this time. CalPERS officials said the employee's only recourse was to write a letter of consideration to your agency, ask for permission to change insurance plans, which I did. After I did that, CalPERS Health and Enrollment called me, and I was told only my employer's HR department can request special circumstance requests for new enrollment outside of the once a year. Today, I'm asking the board to consider approving a special open enrollment for the thousands of CalPERS members in Monterey County so that we can sign up for health insurance plans that allow us to stay with our doctors, use hospitals and our labs for blood work when needed, and use local urgent care providers. Well, thank you for your time And after listening to all the comments today, I also vote for option 1 for those unfortunate employees who work out of state.
Next, we have Braden Graham.
Hi, my name is Braden Grams. I have been working for the state of California for 4 years out of the Chicago office of the CDGFA. There's not a lot more that I can add that hasn't already been said at this point. I wanted to underscore, particularly as a newer auditor, the challenges of starting in at the starting wages with those premiums. I have a family, 2 kids, and a spouse. Those premiums are prohibitive. If we lost our second income, I would be immediately looking for a new position elsewhere. We would not be able to afford those premiums if we had a reduction in our family income. I'm away from retirement. I have 20 years in higher education and other areas. We're actually working on student health plans and other things, so I can appreciate the difficulty of the job you're doing. But I guess I want to underscore that these premiums are prohibitive for recruitment, for retention, and I just want to underscore those points and just kind of reiterate what everyone else has already said. Thank you.
Thank you. Next, we have Osvaldo Osorio. Go ahead, please.
Good afternoon, members of the board. My name is Osvaldo Osorio. I am a tax auditor for the state of California who works in the Houston office. My job as an out-of-state employee is making sure that companies that do business in California pay their dues. We are one of the few income-generating agencies for the state of California, and yet we are also being asked to carry the financial responsibility of premiums. I am calling regarding item 6A because the current recommendation is to do nothing. While I am very grateful to the state of California for all the work experience and the opportunities that it has afforded to me, I must say that the cost of healthcare is outrageous. I am getting married soon, and if I included my fiance into my healthcare program, we are talking about nearly $10K a year in insurance costs. $10K over 5 years could be the difference between us putting a down payment on a house or having to rent for God knows how long. Over 20 years, it could be the difference between us sending our kids to college out of pocket and helping them get an education without the crippling debt, or making hard choices on what we can afford for them. I understand that increasing the cost of California workers' insurance by 2 to 3% may not seem like a preference, but please consider that you're asking us to pay $5,000 a year so instead employees can save $35 a year. Additionally, I heard a spiraling effect point regarding all workers moving to PERS Gold, and I believe that point is just mute, since there used to be an option prior to all of this called PERS Choice, and no such spiral occurred back then. Matter of fact, you want to talk about a spiraling effect? Our agencies in out-of-state have been losing employees because competitors have better pay and better benefits than FTB. Choosing to continue with this non-recommendation would be to just let us completely sink. It will start to give the sign to young auditors and young out-of-state workers that perhaps the state just doesn't consider them when on their choices, and that they should make a career elsewhere. So please, for the financial future of all of us who work for the state of California and the citizens of California themselves, consider going against the recommendation on item 6A and expand PERS Gold. I yield the rest of my time.
Okay, next we have Nicole Casey.
Hi there, my name is Nicole Casey. I'm calling from the town of Truckee, and we appreciate the clarification that this would not impact the ability for employers to continue using the zip code override. What wasn't clear is if this is going to impact the networks of doctors which are utilized by both our in-state and out-of-state employees. Just a background, Truckee is about 30 minutes away from Reno, Nevada, and around 2 hours away from Sacramento, which is the next nearest location for a wide network of specialists. If this would change the list of in-network doctors, i.e. getting rid of the doctors that are available in Reno, we would like to comment that this seems like a costly option for the total pool given the cost effectiveness of the in-network doctors in Reno. To give an example, an MRI in Truckee can be upwards of $1,000 after insurance for the employee, whereas they are typically around $100 after insurance in Reno. If you think that the insurance is covering about 80%, that should give you an idea of how much the insurance pool is covering. By removing the Reno option of in-network doctors, the impact to the pool could be quite costly. This could also be a huge hit to healthcare accessibility for our in-state employees. Truckee is a small but mighty community, and while our healthcare access here locally, albeit expensive, has been expanding, it still lacks the broad network of available specialty doctors. I myself had a NICU baby earlier this year. This experience made me extremely grateful for insurance, but our local hospital can't provide for premature infants. So there is a NICU in Reno, which is only 45 minutes away. The next nearest NICU is in Sacramento, over 2 hours away. I actually did get transferred to the Sacramento NICU, and it was a huge burden on my family. And just thinking about, if this happened to all of our employees, this would just be a huge impact to their healthcare accessibility. CalPERS staff talked about wanting to reduce adverse health outcomes from reduced availability to healthcare, and forcing employees to go 2 hours away is likely to disincentivize treatment. So we urge CalPERS to maintain the in-network doctors in Reno, both from a cost perspective and from a healthcare accessibility perspective. And also, I just want to say, just hearing the comments from our state employees in other areas really makes me want to call the CDTFA and tell them to renegotiate the benefits with these really important workers. Thank you. That's all I had.
Okay, next we have Megan. Go ahead, Megan.
Hi, hello everybody. My name is Megan Knapp. I'm a state of California employee in the Chicago office, Franchise Tax Board. I've worked for California for the last 16 years, so since 2009. And prior to 2022, I was enrolled in the PERS Choice Insurance, which, while being more expensive than the in-state HMO plans, was relatively reasonable when compared to my pay. In 2022, the board decided to provide access to this new plan, PERS Platinum, which has both a higher benefit level of 90% coinsurance, but also much higher premiums. If I had been offered the PERS Gold plan for 2025, I would have saved $12,000. So I just want to say that this disparity has really hurt me and my family. And as a family of four with two little kids, this cost has really created a financial burden and has seriously impacted our financial stability and freedom. So I would like for you to vote for the first choice and take this opportunity to bring equity and affordability back to our healthcare options and allow for the expansion of PERS Gold to out-of-state employees. Thank you.
Next, we have Donahue Milton.
Hello. My name is Donahue Milton. I am actually a newbie. I started last year, not even a year here. I was very excited when I first started to see that SEIU was the union. I am a member of SEIU in New York 1199, and I was a part of voting that union in at my last employer. Unfortunately, that first day of filling out papers, I realized that my cost of health care was prohibitive of me insuring my whole family. Being involved with unions in the past, I've never encountered a union meeting where it seemed as if a part of your people are disregarded. I find that very concerning. I would like just some thought being put into that in this world where unions are a fleeting thing. I think it's important that strong unions remain, and I think it's important also that we fight for every employee. That is all I have to say. I will listen to the rest of the meeting.
Thank you. Next is Vicente Lopez. Go ahead.
Hello, my name is Vicente Lopez, and I am a state employee here in the Houston office. I've been an employee for 25 years, and the healthcare costs have increased exponentially for us. I seem to remember paying between $20 and $30 a month for my healthcare premium back in February of 2000, back when I started. In my youth, I even considered canceling my healthcare until my dad talked me out of it because he said, "You never know what can happen. You always want to have healthcare medication." And to think today, I'm paying over $1,200 a month. So my mindset has completely changed from back then to now. I have a family, and I see now how important it is to have healthcare. But from what I'm hearing here, we've got about 285 employees that have no option. All of us employees who are out of state, we're basically told, you can only have this one particular option, is this or nothing, That's the only options that we have. And also I gather that I didn't know that by us being made available the gold plan, it might increase premiums for in-state employees by 2 to 3%. So I understand that there is logic by having us pay more, but it's almost unreasonable the amount that we have to pay more. By not having a choice, our only healthcare option for the family cost in my case is 635% more than what my peers in state are paying. So essentially we have a 635% premium over our fellow employees in the state of California. My choice between choosing medical care has never ever hinged on having a peer's choice or a peer's care equivalent. And that is basically the 80-20 versus the 90-10. If we need medical care, we're going to go and get medical care. So that has never been a part for us. So, and in addition to the $12,000 premiums, my out-of-pocket cost for the past 10 to 12 years has been over $2,000 a year. So it's like we're getting this very expensive health care, and then we're still having a lot of out-of-pocket costs. Delon Johnson asked me to ask a question, to make a statement as well. And basically he asked me to a question on the comment made on instability for Peers Gold if we join from Peers Platinum. People choose PPOs because they don't have options like us, or they need the benefit of the PPOs have, suggesting that adding out-of-state employees will add instability to Peers Gold is inaccurate. Cost is one of the lower items on the list of when choosing PPO for those that do not have a PPO. And in closing, I want to urge you guys to vote for option 1. I know that the 285 people out of state is a ripple when you consider the tens of thousands of people. Oh, I just one more sentence, and I'm done. I know that 285 people is a ripple when you consider the tens of thousands of people under CalPERS. But even after the stipends are taken into account, we are paying over 300% more than our in-state peers. And also, please note that these stipends can go away.
Thank you for your comment, Mr.
if there's
Lopez.
not a contract, so these aren't guaranteed. Thank you. Thank you so much for your time. Okay.
Next, we have Layla Koshut.
Hi, everyone. My name is Layla, and I'm a state employee for the Chicago out-of-state office. I've been an employee for California upcoming 1 year in June. Honestly, I was very disappointed when I started enrolling in my benefits and I saw that California in-state workers have so many different options when it comes to healthcare and benefits, whereas out-of-state employees only have one option, and it's the most expensive option. Just to kind of give you an example, 21% of my gross pay goes towards the health plan premium, and that's just the premium, right? That doesn't include doctor's visits, my deductible, all that kind of stuff. So yeah, I want to take this opportunity to ask the board members to hear us out.
there only is so much that we can do when we do these public comments, but imagine all of the other employees that haven't had a chance to give a comment. I urge you to think about what we've said and bring equity and affordability back to our healthcare options and allow for the expansion of PERS Gold for our out-of-state employees. Thanks so much.
Okay, next is Shannon Lynch. Go ahead, Shannon.
Hello, my name is Shannon Lynch. I've worked for the Chicago office for 16 years. I just want to thank the board for letting us speak to you on behalf of the lack of insurance options for the out-of-state district. As you can see, many of us are very upset and angry about this topic, and many of these people I've worked with my entire career at the state. Listening to the presentation about the reasoning behind not offering another option for our out-of-state district has made me sad and upset. We are not being treated as California workers and not being given the same options. I think that the presentation reinforced how we feel. We feel like we're not being given the same treatment, and we work just as hard for the state, even though we're labeled as an insignificant amount of people. We bring in millions of dollars for the state year after year, and for us to fight for the same options as our fellow coworkers is unbelievable. And it's easy to disregard us without hearing how we feel about this treatment. Please take our stories into consideration and offer us the same treatment as other California employees. Please vote for option 1. Thank you.
Do we have any more speakers? If
Yes, and next is Anita.
Anita,
Anika
if we
All,
could
go
have
ahead.
the next, we've had quite a number of speakers already speak.
Hi.
So if you can sort of summarize, if there's something new, please sort of summarize what you're saying and don't be repetitive as much as you can. Speak of your personal story. We want to hear it. But if you could keep it to 2 minutes instead of 3, that will help us. Thank you. So the board can get back to deliberating and on this issue.
Hi, yes, perfect. My name is Anika Walls, and I am the president of SEIU Local 1000, and I represent the out-of-state employees in Houston, New York, Chicago, and Hawaii. And I'm just here to speak in favor of option 1. Our employees are suffering from rising costs, inflation, return to office mandates issued by the governor, which all means more pay cuts for our employees. And I'm asking that you consider expanding PERS Gold to our out-of-state employees so that they could have equity and affordability like those of us who live in California, or at least more of it, like those of us who live in California. We definitely hear about the challenges that our employees face given these increased costs, and not only healthcare, but as mentioned prior, in inflation and all the other costs that they're having to deal with. So I please ask the board to consider expanding PERS Gold to our out-of-state employees and voting yes for option 1. Thank you so much.
Next we have Jackie Kapala. Go ahead, Jackie.
Hi. Yeah, I'm a state employee from the Chicago office, and I'm coming up on 18 years of being an employee. And I am an employee who does not have state health insurance. And the reason for that is because of the cost. So I have my husband's insurance, and I am lucky that I have that option. I know a lot of my coworkers do not have that option, and they're forced to pay these high premiums. I am lucky that I don't, but I have had state insurance before. We switched for the sole purpose of the cost. If PERS Gold were an option, it would be cheaper than what I'm paying now on my husband's insurance. And it's probably something we would go with. And I know somebody mentioned, there's only 200 and something people out of state, and this only affects about 60 people. But you're talking active people on the insurance plan. I'm one who's not. There's probably, I don't know how many more not on the insurance. So it is affecting people that you're not even aware of. And then the last thing I wanted to point out is, if you've noticed, all these people on this call are all saying that they've been here 15 years, 20 years, 30-something years. These costs over those years are adding up. And I know, this has only been the last couple of years, but if this continues, those costs are insane. It's not sustainable. So, yeah, I just urge you to consider the options, and I hope that you vote option 1. Thanks.
Next, we have Joseph Carbone. Go ahead.
Hello, my name is Joseph Carbone. I'm a Chicago CDTFA tax auditor. I've been with the state for 10 years. One thing that I know there was mention about, if you switch to that other healthcare or providing the 65-35%, that people won't use it because of the high deductible and copays. I almost feel that way right now because I'm paying so much for the insurance that I'm afraid to use it. Am I going to be able to afford it? So paying the extra $1,000 a month premiums definitely makes me not want to use it and only use it if I really have to. The other concept is with taking that higher premium every month, I'm not able to live a healthy lifestyle that I would really like to. Increase in health or food costs, healthier food costs more. So we got to cut back on other areas that could be more health beneficial as well. So I just want to say definitely vote yes for option 1 for affordable health care, which is the goal for all state employees. Thank you very much.
Next is Kathy Jamal.
Yes.
Go ahead.
Hi, my name is Kathy Jamal. I'm a state employee out of the Chicago office. I would like to request that we be given the option to enroll in health insurance under the first goal, option 1. Similar to our in-state colleagues, currently I'm paying approximately $1,200 a month for health insurance, which constitutes a significant portion of my take-home pay. This financial burden is substantial, and it impacts my ability to allocate resources toward other essential needs, such as my children's education. Although we might be a relatively small group, to my knowledge, we contribute meaningfully to the state of California. Our work generates millions of dollars in tax revenues that support services and improve the quality of life of poor Californians. Despite our contribution, it is disheartening to feel excluded from the same healthcare options available to in-state employees, especially when we perform the same duties and uphold the same standards. I have been with the state for 12 years almost, and health insurance costs have consistently been one of the greatest challenges I face financially. When speaking with in-state colleagues, they are often surprised by how much we are required to pay for health care. Our office continues to perform at a high level, and our revenue contributions speak for themselves. We are simply requesting equitable treatment, the opportunity to choose more affordable health care coverage through the PERS goals, just as in-state employees can. Being denied this option makes us feel second-class employees, despite the quality and impact of our work. We respectfully ask for your consideration in addressing this disparity and vote for option 1. Thank you.
Next, we have Newton Casanso. Go ahead, please.
Thank you so much for the opportunity to speak and for being patient with me. Technology is not the best friend here. I'm working at the office today. So my name is Newton Casanso, as mentioned by the moderator. My personal story is one that I wanted to highlight here. So in 2021, I started as a state employee for the state of California, moving from Virginia to California during the pandemic, and helped the state process all the the unemployment and pandemic plans with EBT. But let me speak about healthcare. So at the time, I started paying for me and my son, and the cost was $300. And quickly moving to last year when I uh, started working as an out-of-state employee, the healthcare rose up to $890. So from $300 with Kaiser 7% of my pay to 21.4% of my current pay. So, and comparing these percentages from 7% in now 21 to something I heard about, different option offered and in-state would have 3% to the increase that I had of 300%. I think the board would do a great service to out-of-state employees by considering option number one. But I also had something different that with only PS Platinum being the only healthcare plan offered, you see that the market is kind of monopolized. And so if different plans are added and different options are given, you see that the cost would significantly be lower for out of state. So, but just to summarize this, the increase in this healthcare cost, I didn't know at the time I was moving here, has really impacted the quality of life that I'm living as a state employee. Could see that a big chunk of my pay is healthcare. It's healthcare, and so at this time, option one would really help me and my family live even more good quality of life. And also moving forward, that more plans and more options are offered, instead of the monopoly in terms of plan that we have here in PS Platinum. Thank you so much.
Next, we have Kim Molinaro. Go ahead, Kim. Kim Molinaro, go ahead. Okay, we'll go to the next caller. Next caller is Win Zing.
Hello. My name is Wenjing, and it's from our pocket. So it's very costly for us. And I mean, if we can think like we perform the same duty as the in-state employee, I think we out-of-state employees should be treated as same. If the in-state employee has so many choices for health insurance, I mean, out-of-state employees should also give this right for us to choose, to give more health insurance, so we can choose a different, better pays, less deductibles. So that is really kind of like it's like we do the same thing, but we don't treat the same way. So I hope the state can consider out-of-state employee, even we are not like a majority, we are minor, small portions of employee, but please consider to give like same rights of the health insurance. So make us can choose, for the different choice. So thank you.
Okay, next we have Soren Kishan. Go ahead.
Hello, my name is Soren Kishan. I'm from the out-of-state office from Chicago. I've been with the state for 16 years, and I'm not going to repeat everything was said here, but thank you for the opportunity to speak, to allow all of us to speak with you today. Thank you to the board members. I want to urge you to choose option one for us, because what we have right now, it's really, really bad, and we barely making it to the end of the day, to the end of the month. We need your help to consider, to change, to have an impact. Take a decision finally, and out of state employees, please. I pay a family premium for $1,200 per month. I'm a healthy person. I barely use the insurance. Okay, my wife is pretty healthy as well. We barely use the insurance, just annual checkups, right? My older kid doesn't use the insurance, just annual checkup, right? Barely using it, right? Our exposure is 14 for a $100,000 salary. Let's say it's 14%. For a $60,000 salary, it's maybe 20 something percent. Just without using it, without having co-payment, co-insurance, anything like that. So it's huge to have that impact just to pay the premium for a plan, and we have no other option. If by any chance one of us is sick, and it's happening, I have that case in my family right now. The little one was diagnosed, and she needs to have some expensive therapies, ABA therapies. She's gonna reach the maximum. So the maximum out of pocket for our platinum plan is $14,000. So our exposure for a family could be almost $28,000, $30,000 per year. It's 50% from a person that starts the job today, or 30% or 25% for my salary. It's huge, and our plan that we have currently is called Platinum. Everybody will say, "Oh, it's great, right?" So let me tell you something what happened to me. It's a personal story from December, or January actually, January 2025. The director for the center where my kid goes to therapy called me and said, "Sorry, your insurance changed. What's happening?" No, it's the same, almost the same, like still platinum, whatever. No, something changed here. But like, I have at this center, I have 30 families like you. From 300 families, I have around maybe 30 families with the worst insurances like yours. And I was floored. I know how much I paid last year because you were in the center last year too. What do you mean? Well, look, this co-insurance ends at $2,500 or $2,000. But like, you have the copay.
Your statements, sir?
Yes. Sum up. I still have my 3 minutes, right? So what I'm trying to say is that the co-payments do not stop for certain things. So people are looking at co-insurance. The end of the day is our exposure is huge. To have an exposure, we have somebody sick. We're not even talking about that, having somebody sick in the family. And you have to pay the maximum $14,000 maximum out of pocket on the top of the premium.
Thank you for your testimony. Please, next
I don't
one.
wish anybody
Can we go to the next speaker, please?
Next, we have Brianna Johnson. Go ahead, Brianna.
Hi, my name is Brianna. I've been with the Chicago office for 14 years now, and I just want to reiterate to the board that this is for a 2026 action, and this is not set in stone, that if we decide to go with option one, you can still change your minds going forward, 2027, 2028. The thing is, if we pick option one and then maybe in-state will have an outcry because they have to pay an extra $50 a month. Maybe CalPERS will actually come up with a beneficial plan for not only out-of-state, but in-state as well, kind of thing. I feel with going with option three, we are just kicking the can down the road. It's not helping anybody, and the fact is that now it's not fair. It's not right. And the fact that you just want to continue moving it down the road is also not right. If you guys choose option one, that will save families $12,000 next year, and in-state will pay $600, right? The difference is astronomical, and the fact that we're thinking that this is going to be unstable going forward. You have an option to change that for 2027. Let's try 2026. See how it goes. See if it would be unstable. See if people get out of it. The thing is, we need to do something for out of state now and
to make it equal across the board. It's not, again, it's not fair and it's not right. And I urge you guys to choose option one. Just test it out for a year, and maybe CalPERS will come back with something that's actually a better plan for us. Thank you very much, and I hope you guys choose option one. Thank you.
Next, we have Vanessa Clark. Go ahead, Vanessa. It looks like Vanessa's call was dropped. Oh, she's back. Hold on. Vanessa, are you there? Vanessa, are you there?
Yes, I am. I don't know why I was disconnected. Hi, I don't know if you guys heard the beginning, but my name is Vanessa Clark with the Chicago office, and I've been with the state around 11 years. And it's disheartening to hear that we don't have equitable treatment compared to other state employees. I know that the state likes to promote equity, and of course, when you can't even have equity for employees, it does show lack of, just loyalty to our employees, especially with all the work that we do for the state of California. It's also, I would have to say that the fact that we don't have any options, it makes it hard for families, especially families that have other ailments and things to deal with. And also, I have to say that our benefits have also dwindled throughout the years, and things that they offered, such as subsidies, have decreased, and they're not having the choice of the, I think it was PERS choice. I would say that it has also made things a lot worse for out-of-state employees, and it's going to affect retention. I guess that's all I have to say, and I would hope that you guys would choose option one so we could have more equitable treatment among state employees. Thank you.
We have no more callers in the queue.
Thank you very much. Let's move to our comments by our trustees here. We'll start with Trustee Jose Luis Pacheco, committee member.
Thank you. I'd like to say, first of all, I was very moved by all 26 comments regarding all this. I do see the urgency of these important things in these particular things out of state. However, I want to understand something about option 3, if that's going to be some clarification. Does that align with our duty, our fiduciary duty of loyalty with respect to that? If someone can give me some clarity on that.
I'm sorry, your question, Director Pacheco, is whether option 1 aligns with our
Option 3. Option 3, yes, sir.
Option 3, remind me what else.
To not make the changes, to not advance the out-of-state gold option. Status quo.
Status quo. Yes, it does align with our fiduciary duty.
It does. And then and the other two, the other options.
All
one.
3 of them align with our fiduciary duty.
All three then. So
Yeah, these are trade-offs that have to be made sometimes, and it's within this board's discretion to make them, balancing the considerations that you have been discussing and you have been hearing from the constituents.
Oh, I see.
It's not so extreme on either side that it would be a breach of fiduciary duty to adopt one over the other.
Or the other as well. And then is there, if let's say we were to adopt the recommended status, would there be, based on all the comments that we just received right now, all 26 comments, which were again very moving and very, very valid in my opinion, do you feel that there would be options to explore legislative or Cal HR options later on as an additive to explore and get some more feedback later on?
certainly sounds like that, but I'll defer to program on that question.
Yeah, to Don, yeah.
All of those continue to be options. The conversation with CalHR, I can't speak to, but that is certainly one approach. It's been used in the past. I assume that is what underlies the existing subsidies for people living in out of state. And as those costs have gone up, I can't speak to the schedule of bargaining and when those conversations would need to take place, but that is an avenue for addressing this at any point between now and 2026.
So there is time then to address those issues then.
We have
Yes.
we have an action today. I mean,
Yeah.
let's.
No,
any more-
I just no. Those are it then. Thank you
Thank
so
you.
much for your comments. Appreciate it.
President Taylor, please.
Yes, I want to thank my co-California workers. I'm a state worker at Franchise Tax Board as well as, and I do understand what you're going through, and I heard all of you. I will also acknowledge that while these, the only good option for you is option one, is not a good option for the rest of the 26,000 employees. However, I am going to vote with you guys on this, and I would like to make a motion to move this recommendation.
And what is your recommendation, please?
The recommendation on from the
Option
staff.
three? Option three. Okay, and it was been second. So, we still have some other speakers. Do we want, I'd rather
You
have
can
hear
still,
the
yeah,
other
you
speakers
can
first,
still-
and then we'll go to the motion on the floor. The motion is to go with the staff recommendation, which is option three, which is to continue the current, do not offer out-of-state PERS gold plan for 2026, and that way there'll be no impact on in-state premiums. Okay, next we have Trustee Miller.
Yeah. This is particularly painful, and I'm not one to sugarcoat things, but I'll tell you, listening to the callers and having looked at these situations for so many years, I mean, I've been around this stuff for a long time, and it's kind of unavoidable that we're going to have disparities when it comes to the delivery of healthcare. And historically, we haven't heard as much about the disparities for our out-of-state employees as much as we've heard about the disparities within state, particularly for our the rural members who are living where it's difficult to find access to quality health care that's affordable to them, and it's difficult for us and the employers to make sure they get it. And historically, we've had subsidies for rural health care. And maybe we need to have that again. Maybe we need to revisit the issue of subsidies for our out-of-state to help with these. But that's, as a CalPERS trustee, we can't be the ones who fix these issues. I've been a state employee representative and a union member and officer for most of my career. But I will tell you, to me, this looks like a failure of collective bargaining to address these issues to the satisfaction of everyone. And you almost never will address them to the satisfaction of everyone. And so I will kind of grudgingly support option three as well. But I also think that this, for our friends at SEIU and for our friends at CalHR, with whatever we can do in terms of informational support and partnership, this needs to be worked on. There needs to be better solutions, and those need to come from the bargaining table, in my opinion. Thanks.
Thank you, Mr. Miller. Ms. Ortega? Oops, sorry, I somehow lost you.
I just want to make sure I understand a couple of things about the total numbers of people we're talking about. So the in the option one discussion, we have 26,000 out of state participants, healthcare participants.
Correct, that's correct. And they are a mix of state employees, the 258
Yeah.
that we're talking about, as well as early retirees, as well as public agency members who live across the border, all of them. So every type of flavor is in the 26,000 number.
Yeah. And then the bullet point that says the premiums would increase 2 to 3%, that would apply to a number much larger, right? Like 236,000?
240,000 members, yes.
Okay. So I mean, I think that's important in terms of the understanding of who the 2 to 3% increase would impact. And then I think the other piece of that is the 258. We have a process outside of the CalPERS board environment to revisit that issue. The subsidies that exist were negotiated a couple years ago. The premiums have obviously gone up twice over that period of time as well, and will probably continue to go up. So while we have a process for addressing that narrow issue, it would not address the 26,000 who would still be out of state and have only this one option. So I think that's also important to recognize that while we may be able to address a problem on the one hand, you may still be hearing from people on the other. And then the other thing that I still think we should, and we obviously can't resolve this here, but we should still consider what other options there are for looking at whether the statute needs to be amended or seeing if we can explore other things outside of the parameters we've been looking at, because some of the callers were comparing kind of the cheapest HMO in-state costs to the PPO cost, and they're not the same benefit, obviously. And then also, that's going to always seem like something that we're chasing. We're going to always have those cheaper in-state options. And so it feels like there will never be a satisfactory answer to this if the only option for out-of-state people is always the most expensive option. It will always seem like they are disadvantaged. So I still think we should really explore whether there are any options to having other benefits available to out-of-state, both the actives and the retirees. Thank you.
Thank you for your comments. Vice Chair Pocky.
I ditto. But this cannot be a conversation of us versus them. Regardless of the state, healthcare is expensive. We know that the premiums are climbing higher and faster than the cost of living. So the more that we can use our voice to address this issue, the better. And if I can help support that, please let me. But as a fiduciary, we also have, we owe it to our members to provide high quality and affordable plans. So any sort of option that would increase premiums or degrade the services to those members, I think we should steer clear of. And that's why I'm in favor of option 3.
Thank you, Mr. Pocky. We have heard a lot from our impacted members, to use Mr. David Miller's word, painful. That is their reality. Our reality as board members and committee members is to do what is best for, we think it's a fiduciary duty for the people we are beneficiaries. And it's a tough situation, but we have a motion on the floor, and I would call for the question, call for the vote. So can we have a roll call, please? And the motion, just to, if I can rephrase it.
Is the staff's recommendation.
Staff recommendation, option 3.
Sorry.
Kevin Palkey,
Aye.
Malia Cohen,
No.
David Miller,
Aye.
Morena Ortega,
Aye.
Jose Luis Pacheco,
Aye.
Teresa Taylor,
No.
Yvonne Walker,
Aye.
Melissa Willett.
Abstain.
Thank you. So the motion passes. This is, just want to speak to our members who have taking time to call from out of state. We heard you, and unfortunately, the options before us are tough situation, tough decision. But the board has made the committee has made a decision. But we will take it as direction to staff to look for what can be done. I guess on statutes, we need to see what other options are available. And the other one is not direction to the staff because it's not in their hands, but we would encourage the parties of the union and Cal HR and any other interested parties to sort of forge a look at what can be done on increasing subsidies for people who are out of state, and as Mr. Miller has mentioned, also look at people in rural areas. This board, this committee has strived very hard to ensure that there's quality outcomes for everybody. We want people healthy, and that's why we're doing we had the other discussion about the value-based insurance plans. And we've introduced quality value networks because they do lower premium costs and they create competition on those in other counties. And I'm proud that for this plan year, we were able to introduce and expand those value networks into new counties. So we're hopeful that through this, through other RFPs that we're doing, we will be able to improve the quality of care for everybody and secure our objectives of affordable quality health care. And we look forward to more reports from staff. I think final comments, please.
If I could, Mr. Chair, I just wanted to remind the board that over the last 3 or 4 years now, we've worked very hard to expand lower cost HMO options and now have them available in every county in California. So that is that was not the case 4 and 5 years ago. We still do not have them in every zip code in California, but they are now in every county, and we are closing those zip codes all the time. So that's I just wanted to mention that we are trying to do that and create low cost options, particularly HMO options, everywhere we can. So as soon as that is a live possibility, we will be closing on those.
Mr. Moles, that's very, very beautiful that you said that, and I appreciate it. We have been here a long time, so I know we only have a couple more items to go, but I think it's appropriate that we take a lunch break. And we will resume at 2:15. Thank you.
So Ramon, I had a question.
No, sorry.
It's okay.
You'll go first. Thank you. We're back in open session, and we will continue with the agenda. But before we do that, I did just want to clarify the committee direction, Don. One, again, thank you for your comments outlining CalPERS' recent work on ensuring quality and affordable health care and our goals in that area. But second, I did want to clarify the committee direction that we do, the committee would appreciate a report back in our June meeting, which is the first public meeting of the committees, the next public meeting of the committee. And if you could just give an outline of what your research has produced in reviewing the legislative authority, the statutory authority, and be creative and thinking outside the box, of course.
We will endeavor to do all those things, Mr. Chair. Thank you.
Thank you. Okay, now we'll proceed to open enrollment results. That's item 6A, Health Benefits Program, wrong one. 7A, Health Open Enrollments Results. Mr. Molds and Rob, Judge Smoke.
Okay.
Czar Smolpik.
Good afternoon, Mr. Chair and members of the committee. This is agenda item 7A, which is Health Open Enrollment Results. The overall transfer rate from last year's open enrollment was 3.9%, and this is lower than the prior year, which had a transfer rate of 5.6%. This means that about 30% fewer members made a plan change during open enrollment a few months ago compared to the prior year. The lower transfer rate last year is likely due to lower premium increases for Kaiser and our PPO plans compared to the previous year. Additionally, all basic plans continue to be available going into 2025, unlike in 2024, when HealthNet SmartCare was no longer an offering in our program. As is typical, most migration did occur within the basic plans, which had a 4.5% transfer rate. This equates to about 55,000 members who made a plan change during open enrollment. Medicare members had a 1.7% transfer rate, or roughly 5,900 members, slightly higher than the previous year's transfer rate of 1.5%. This was likely due to the exit of 2 Medicare Advantage plans from our program. Public agency and school members had a 4.5% transfer rate, while state members transferred at a lower rate of 3.5%. Here are the 3 basic plans with the highest net gains. Blue Shield Access Plus experienced the largest growth in members, increasing by 5%, or a net gain of over 6,200 members. UHC Alliance saw a 3.75% increase of 2,800 members. And UHC Harmony had the most significant percentage increase at almost 34%, largely due to having the second lowest premium for the basic plans. About 2,600 members joined Harmony. Now let's look at the basic plans that experienced the most net losses. Kaiser Permanente declined by just over 1%, with a loss of over 6,200 members. PERS Platinum saw a 3.75% drop in membership, or about 4,100 members. And Anthem Select experienced almost a 10% membership loss of around 3,100 members. Anthem Select's 2025 premiums had an increase of over 10%, which changed their pricing position in Region 2 as they moved up 3 places, surpassing Blue Shield Trio, UHC Alliance, and Sharp. In all other regions, and for the state, they stayed at the same pricing position of being the 4th highest plan in our program. There were several basic plans that expanded into new areas in 2025 that we'd like to walk through. Starting with UHC Harmony, which expanded into 3 counties, Contra Costa, Solano, and Napa. Napa County was a full expansion, while Contra Costa and Solano counties were partial expansions. The numbers shown represent the members who newly elected UHC Harmony in these counties. As I mentioned, Harmony's overall membership increased by 34%, and they added about 2,500 new members to their plan. Blue Shield Trio expanded into 2 counties, again, Contra Costa and Shasta. In Contra Costa, they gained about 200 members, and in Shasta County, it was a partial expansion into 3 zip codes, and they added 14 members. However, in Monterey County, TRIO lost about 15% of its membership, roughly 1,000 members, with most of these members switching plans to PERS Gold. Overall, TRIO's membership grew by 1.5%, adding approximately 700 new members. For HealthNet Saluti Moss, their overall membership decreased about 4.5%, despite picking up 176 new members with their expansion into Imperial County. The new members gained in Imperial County was below HealthNet's projections, but they expect better results in future years as their offering becomes more well known in that county. One potential cause for their overall decrease in membership is that Saluti Moss had the highest premium increase of almost 15% amongst the basic plans. However, they are still the lowest or second lowest offering in our program. In Region 2, UHC Harmony is the lower priced plan. The last basic plan expansion is Kaiser Permanente. In Monterey County, Kaiser expanded into 14 zip codes in the northern region, adding 178 new members. This was in line with their initial projections. Overall, and as I mentioned earlier, Kaiser experienced a net loss of approximately 6,300 members, or about 1%. Moving on to Medicare. The Medicare plans that experienced the highest growth were Blue Shield and Medicare Advantage, as they gained about 1,400 members, reflecting a 19% increase. Kaiser Senior Advantage Summit, which grew by almost 7%. And UHC Group MA that had a net gain of 1%. This last table covers the Medicare plans that experienced the largest net loss, 2 of which are no longer in the CalPERS Health Program, starting in 2025. One of the terminating plans is UHC's Edge. As you may recall, UHC proposed a premium increase of 50% going into 2025, or from 2024 going into 2025. This would have made Edge the most expensive Medicare Advantage plan we offer. UHC didn't see a path back to lower premiums, and the board approved its removal from our program. The second terminating plan is Western Health Advantage MyCare Select. WHA's decision to no longer offer an MA plan applied to their entire book of business and not just CalPERS. While this was disappointing, it did not come as a surprise, as the landscape for MA plans has changed drastically since they introduced their offering just a few years ago. Like all members enrolled in a terminating plan had the option to make a plan change during open enrollment. But if no action was taken, they were moved to a default plan, which was the case for the majority of the impacted members. For UHC Edge, 81% of members moved to the default plan, which was UHC Group MA. For Western Health Advantage, we had 2 default plans depending on where the members lived. First was Blue Shield's Medicare plan, and second was UHC's Group MA. 2/3 of the population moved to the Blue Shield offering. Outside of the Medicare plan terminations, Kaiser Permanente Senior Advantage experienced a decrease of less than 1%. Those members changed health plans to Kaiser Senior Advantage Summit, so still within the Kaiser system, PERS Platinum, and UHC Group MA. This concludes my presentation, and I'm happy to take any questions.
Thank you very much for that excellent presentation. Any questions from the committee? I see none. Oh, sorry, I do have a question. Vice Chair Kevin Palkey.
With the moves from one provider to the other, have we collected data on satisfactory or the satisfaction of going from one plan to the other?
Do you mean for these members who changed plans, or
Yeah.
from the Anthem to Blue Shield transition?
From the members that changed plans.
For the members that changed plans, we could capture them in our annual member survey to see what the member scores are for their new plan for the new year, but we haven't captured it yet.
Okay. Thank you.
Okay, thank you. We do have public comment on 7A. Jay Jelensic.
Good afternoon. J.J. Jelensic, Director of Health Benefits, RPEA. Your risk adjustment plan is working just as the board designed. The biggest loser was Kaiser, which costs $935.24 for the insurance, plus $109.96 for the surcharge intended to discourage people from picking Kaiser, for a total of $1,045.20. The biggest gainer was Blue Shield Access Plus, which costs $1,124.64 for the insurance, less the $158.78 subsidy designed to encourage people to pick the higher cost, less efficient plan, for a net of $965.86. Kaiser has lower insurance costs by $189.40 per member per month, but a higher collected cost of $79.34. I'm still trying to understand how this is supposed to help control costs. Most of my members are in Medicare, but anything that encourages higher medical costs will eventually flow uphill or downhill over time. So I really ask you to look at your risk adjustment, and I thank you for your time.
Thank you. We will now proceed to 7B, the Preferred Provider Organization Transition Update. Rob, is that you?
Yes, thank you again, Mr. Chair. And good afternoon, Mr. Chair and members of the committee. This is agenda item 7B, which provides you with an update on the PPO transition to Blue Shield of California and Included Health. As you know, moving 400,000 members from the previous third-party administrator that served our members for 2 decades is a significant undertaking. So first and foremost, I would like to thank our members and employers for their patience and understanding as we make this transition to our new partners. We know this has been bumpy for some members, and we are doing everything we can to make things right when we are not delivering the service or experiences we want to. The member and employer input we received throughout the process has helped us address issues as they came up, as well as improve our communications and ability to serve our members. All organizations, CalPERS, Blue Shield, and Included Health, are all committed to getting things right so our members get the care they need and have an experience we can all be proud of providing. We have 5 topics to cover with you today, and we'll start with member communications and support. When Included Health began providing their full suite of services to basic PPO members in January, they experienced very high call volumes, at about 6,000 per day at its peak. This unfortunately led to long wait times for our basic members, which is unacceptable and not consistent with the level of customer service our members have become accustomed to and deserve, nor was it the exceptional experience Included Health is used to providing. Most of these calls were about the primary care provider, or PCP, listed on a member's ID card. In some cases, it was not the PCP that members had been seeing in the past. To address this, the CalPERS team, along with Included Health and Blue Shield, worked on an action plan to decrease call center wait times and also help members select a new PCP. We developed several communications and FAQs to educate members about PCP matching and how to change their PCP. Blue Shield also added more available providers to the networks, and Included Health added additional agents to their call center. In terms of call center metrics, for January and February, 62% of the calls to Included Health were answered within 30 seconds. The metrics are steadily improving, and we expect that Included Health will soon meet its performance target of answering 90% of calls within 30 seconds. The year-to-date member satisfaction rate for Included Health is 75% and is also steadily improving. Similarly, Blue Shield has seen higher than usual call volumes for the Medicare supplemental population and has maintained their service levels. The primary reasons that Medicare supplemental members are calling Blue Shield are with questions about both eligibility for both medical and pharmacy benefits, questions about benefit changes, and lastly with claims inquiries. Additionally, it's important to note that the provider network for Medicare members has not changed. A Medicare supplemental member still has access to the providers and is not impacted to the change of our third-party administrator. So Medicare supplemental members can continue to see the same providers in 2025 as they did last year, despite our transition to a new TPA. Given the high call volumes to Included Health these first couple of months, the CalPERS team is monitoring the member experience and also the accuracy of information provided by Included Health. We're doing this by listening to call recordings each week and providing feedback and opportunities for coaching. The CalPERS team has also reviewed all of Included Health's training materials to ensure their agents share accurate and complete information with members. We are also working to enhance and improve the Included Health app so that it provides a more customized experience for CalPERS basic PPO members. This includes improved navigation to help members understand how their benefits work, such as the free lab tests through the Site of Care program, as well as a new doula program. Moving on to continuity of care and services. While most basic PPO members are able to continue seeing their existing doctor as an in-network provider, CalPERS has contracted with Included Health to help match members with high-quality in-network providers should they need one. Also, together with Blue Shield, we put in place certain safeguards to ensure that members could continue to access needed care if their current provider is no longer in-network due to the transition. First, for members undergoing treatment for certain medical conditions, if their current provider is no longer in-network in 2025, we implemented a continuity of care policy that ensures members can continue to see their current provider with in-network benefits for up to 12 months. We also established a limited out-of-network exception program for primary care, specialty, and behavioral health office visits in the interim, while Included Health helps members find an in-network high-quality provider. For continuity of care, there have been about 1,100 requests at the end of February, and roughly 950 have been approved. The majority of the rest are also pending approval. For the limited out-of-network exception, there have been about 100 requests as of the end of January, and the majority of those have been approved too. The next topic is care management and member navigation. And the good news is that we know members are already connecting with Included Health's clinical and care management services. From launch through February, Included Health has provided over 21,000 referrals to high-quality providers for CalPERS members. Since the start of the year, nearly 300 members signed up for Included Health's care management program, and about 1/3 of these members enrolled in the maternity program, which is a higher number than we've seen in recent years. Included Health has already conducted expert medical opinions, provided treatment decision support services, answered calls with triage nurses, and completed concierge referrals, many of which include referrals to high-quality PCPs. As a matter of process, the CalPERS clinical team also reviews the high-cost, high-needs members on a monthly basis with Included Health and Blue Shield, and Included Health is doing outreach to this vulnerable population. In terms of Included Health's supplemental virtual services, members are taking advantage of access to Included Health's primary care, urgent or on-demand visits, and also virtual behavioral health visits with therapists and psychiatrists. Through February, there have been almost 1,100 virtual primary and urgent care visits and over 550 virtual behavioral health visits. It's still early days, yet we are encouraged that members are already using these new services offered by Included Health, which were intended to improve and expand access for our members. Last but not least is our partnership with Blue Shield and Included Health. From the outset of this implementation, our teams have met regularly at both the executive and operational levels to ensure we have clear communication and strong coordination. The CalPERS team has worked with Blue Shield and Included Health to develop workflows and processes to ensure smooth handoffs and an optimal member experience for a multitude of areas, such as continuity of care, access to care exceptions, and patients needing care management services. We continue to monitor and iterate on these processes, such as our recent work to improve the handling of grievances and appeals, and also discussions to improve the screening and handling of continuity of care requests. As we begin to transition out of the implementation phase, and as Don mentioned, the CalPERS, Blue Shield, and Included Health teams had an in-person executive meeting last week where we had a very open and productive conversation on what's worked well and what areas we need to improve. We developed partnership principles to help guide us and our teams as we embark on this unique three-way partnership. As I stated earlier, we are all committed to getting things right so our members get the care they need and have an experience we can all be proud of providing. In closing, I cannot underscore enough how large of a transition this has been. We again want to thank our members and employers for their patience and understanding and for their feedback they have shared with us as we go through this implementation. We recognize a handful of issues have emerged this year, but most of these are resolved or on a path to resolution. I'd like to recognize the amazing and dedicated CalPERS, Included Health, and Blue Shield teams who have worked tirelessly to resolve issues as they are identified to ensure our members get the care they need. This concludes my prepared remarks, and Don, Julie, and I are happy to answer any questions.
Thank you, Rob. Questions from the committee? Okay, I'll call Mr. Pocky.
Not so much a question, but I too want to share my thanks to you and the teams for making the transition as smoothly as possible. So thank you for that.
We have Mr. Pacheco.
Yes, thank you, sir. And thank you, Chairman Rubalcaba, and thank you, Rob, for your presentation. I just have a question regarding the transition. During the beginning, I think it started in January. Was it January 1st that we did the transition? I had heard that there were, some hiccups with respect to making the phone calls and the customer service lines, and we had to utilize more additional resources and so forth. Has that all been resolved, or and how is it? What have we done to mitigate those issues?
So as I mentioned, that we did experience, Included Health did experience some very high call volumes at the first of the year. And so we worked together to understand why members were calling, so what the issues were. And the primary issue was the PCP, or primary care physician assignment, that was done by Blue Shield. So it was just different than some they had with the previous third-party administrator. So we clarified and simplified the process for changing PCP so members can now match to a new PCP. We also created with Included Health, they created a voicemail box where members didn't have to wait online if they just wanted to change their PCP, so they were able to do that and leave a message and it would be handled. And then Included Health also added additional agents to their workflow, to their workforce. And so those are a variety of things that we've done. So far, the call stats for this month are much more in line and much closer to what their performance targets are. So things have definitely improved from the call wait time perspective.
Oh, excellent.
And if I can just add a little bit on that. So one of the challenges, as Rob mentioned, is that the volume not only was higher initially than anticipated, but it stayed high. And so Included made the decision to train a number of new folks to be on the lines to address that issue. Two things emerge when you do that. One is that you have to train those folks, and so it takes time. And the second can be quality issues. So they had the luxury of the whole fall to work with the folks who are on January 1st as they augmented. They were training, but also trying to move them to phones as quickly as possible. We were monitoring the quality of the calls. Included projected some initial challenges and then an improvement, and that's basically what we've been seeing. So the quality of the call, in addition to the wait time challenges and the improvement there, we've been seeing improvements in the quality of calls too. They're also learning us. We're different than a standard commercial employer. Most of the rest of the folks they work with are that, and as they continue to learn us better and our members' needs and so forth, that quality will continue to improve as well.
In addition to that, were there any language issues, like were there more Spanish speaking customer service or anything like that, or did you experience any of that?
No, not that has been raised to us, no.
Oh, excellent then. And then finally, the last question I have is continuity of care with respect to the, I believe we provided, if the members weren't able to connect with their PCP, that they could still continue with their current PCP for a continuity of care like 12 months. And how has that been going?
So that's been going well. So we've received Included Health and Blue Shield have received about 1,100 requests at the end of February, and the vast majority, 950, have been approved.
Oh.
And so these are for certain specific conditions that the member has. So we want them to be sure to continue that continuity with their provider.
And these are specialty physicians and so forth?
It could be any acute condition, a serious chronic condition, pregnancy, terminal illness, child care of a child under 3 years old, or a previously scheduled surgery. So a variety of different things.
A variety of different things, but as long as they have that continuity care, that it's still in process, and that's being coordinated with Included Health, correct?
Correct. Yes.
Okay. Very good then. Those are all my questions. Thank you, sir.
Thank you. I too want to join with my colleagues and thank you for the work on this transition. Like your memo said, is very complex, but on the other hand, it's also very forward-looking because we're adding Included Health, which is a population health management, and we're adding a new third-party administrator, which we for the PPO, which we believe will provide better quality care, coordinated. And so we're looking forward to whenever we can get data on whether we see improvements as people meet with their primary care physician and coordinate on, say, depression screenings or whatever things that have been falling through the cracks. I look forward to a report maybe in June or whenever there's something available as to how that is working out, because this integration is very exciting and looking forward to seeing results of this decision the committee made. Thank you.
Mr. Rubalcaba, I just wanted to add to that. From a clinical perspective, my team is looking at all of the things that you mentioned in terms of outreach, engagement, chronic care management, and making sure that not just sort of the process measures are checked off, the how many people and all that, but what are the impacts to their lives and to their health. And so, like you mentioned, depression screening, anxiety screening, are they getting their A1C, their diabetes screening, things like that. So we are certainly tracking that on a monthly, quarterly, and annual basis.
Thank you. That's what we want to hear. Thank you. Not seeing any more comments or questions from the committee, we'll move on to item 7C, Retiree Cost of Living Adjustment 2025.
Good afternoon, Chair Rubalcaba and the members of the committee. Kimberly Polito will be presenting our COLA item today on behalf of Customer Support Services Branch. Kimberly is the division chief of our Retirement Benefit Services Division, so I'll turn it over to her.
Thank you, Kim. Good afternoon, Mr. Chair and members of the committee. Kimberly Polito, CalPERS team member. Item 7C is an annual information agenda item on the retiree cost of living adjustments, or the COLA. As background, our retirement law provides for the payment of an annual COLA each May to all eligible retirees based on the rate of inflation as measured by the Consumer Price Index, All Urban Consumers, or the CPIU. For calendar year 2024, the rate of inflation over the prior year was 2.95%. The COLA adjustment is dependent on three factors. The CPIU, which I just mentioned, increased by 2.95% this last calendar year, the employer contracted COLA provision, and the year of retirement. A member's COLA increase to their pay is limited to the lesser of two factors, the rate of inflation or the COLA provision that their employer negotiated as part of their contract. Both of those compounded since the year of retirement. A retiree becomes eligible in the second calendar year of retirement. Therefore, members who retired in 2023 or prior are eligible to receive a COLA benefit this year. Nearly 96% of our retirees are contracted for a 2% COLA, but some do have a 3, 4, or 5% COLA provision. COLA adjustments will appear on the May 1st warrants or retirement checks. There are instances where the COLAs do not adequately keep up with inflation over the long term. We generally experience this with our retirees that have been retired for 35 plus years. The Purchasing Power Protection Allowance, or PPPA, works in conjunction with COLA to ensure our members retain at least a specified level of purchasing power. In Government Codes 21337 and 21337.1 of the CalPERS Public Employees Retirement Law, or the PERL, the purchasing power threshold is 75% for state and school members and 80% for public agency members. The PPPA adjustment, like the COLA, is payable on the May 1st retirement check. To illustrate the impacts to the total retirement allowance this year, we've included in the agenda item charts showing the allowance increases by retirement year, including COLA and PPPA. On this slide, we've highlighted the impacts to those with a 2% COLA provision, as these are the increases the majority of our retirees will see. Those with a 2% COLA provision will receive between 2 and 2.95% increases in their allowances. Charts reflecting the allowance increases for the 3, 4, and 5% provisions are also included in the agenda item. COLA increases are always of interest to retirees, so we do our best to communicate through various channels, including My CalPERS, an article in our spring newsletter, The Perspective, various social media platforms, and updates on our CalPERS website, including the charts in the agenda item and dedicated web pages for both COLA and PPPA. This concludes my presentation, and I'm happy to take any questions.
Thank you. Comments or questions from the committee members? Mr. Pacheco.
Yes. Yes, thank you, Chairman Rubalcaba, and thank you very much for your presentation. I always appreciate this presentation and the COLA. It's really awesome to see all this information. I just want to go back to the communication and resources. You had mentioned that you communicated through the Perspective article and through the website. Are you also going to have any stakeholder meetings with the relevant stakeholders?
We actually just updated the stakeholders last Thursday and provided this information as well.
Yes, absolutely. That's wonderful. And then with respect to the PPPA purchasing power provision allowance, now what's the percentage of that is associated with the retirees?
A very small percent. In fact, we have just over 16,000 members that currently are supplemented with the PPPA. And again, those are going to be the retirees that retired in the 70s.
In the 70s.
70s and 80s.
Okay, so that's a very, very tiny group of people. Okay.
Yes.
That's it. That's all my questions. And thank you so much. And again, I appreciate this information and all the work that you've done. Thank you.
Thank you.
I too join with the committee members to thanking you for your presentation and report.
Thank you.
Okay. Now we move on to summary of committee direction.
I recorded two items. First is to report back to continue looking for better, more affordable out-of-state options, including but not limited to changes in statute and continued conversations with CalHR. And to report back at the June board meeting on that. The second one was to report back at the June board meeting or when appropriate an update on the PPO transition.
Yes, basically the net health quality metrics. Thank you. Now we go into 7E, which is public comment. We have JJ Jalentic.
J.J. Jelensik, Director, Health Benefits, RPEA. The board had approved a draft agenda with the healthcare spotlight. Staff, however, decided not to have one. But I think the spotlights have value. But I want to point to, and there's a handout that I had that you should have gotten. Anthem Blue Cross has two plans, a select and traditional. Same insurance companies, same benefit design, no indication of health differences between the two groups, but different networks. Again, reflecting the board's preference for high-cost plans, the lower-cost, higher-efficiency network gets hit with a surcharge of $79.69 per member per month. The higher-cost, lower-efficiency network gets $114.13 per member per month subsidy. The board's risk mitigation scheme really mitigates against two risks. One, that a plan will develop a lower cost, high efficiency network and gain subscribers. The second is that a plan will price itself out of the market by maintaining a high cost, low efficiency network. It is not clear to me how this scheme serves your fiduciary obligation to the beneficiaries or your secondary obligations to the employers and taxpayers. It is unclear how the scheme complies with Government Code Section 22864A or is consistent with CalPERS health belief that, quote, PERS shall manage competition among health plans to drive cost containment, unquote. I assume that at some point the legislature, a public interest law firm, a class action law firm will give you the opportunity to explain it. I point out that at that point we will also learn whether your self-dealing contract with the system will hold up or is a violation of Government Code Section 1090. Thank you.
Since we do not have any further public comment, this adjourns the meeting. Teresa, when do we meet again on the governance?
Give us 10 minutes to switch.
Okay, 10 minutes, everybody. Thank you.
I think I have one thing to cover in board governance. David.
Here.
Frank Rufino for Kiwanama.
Present.
Rowena Ortega. Here. Ramon Rubacava.
Present.
Yvonne Walker. Here.
All right, with that, our next order of business is the election of the board governance chair and vice chair. I'm going to hand the gavel over to Mr. Miller. Here. Ready?
Got the gavel and the microphone now.
You gotta use
Okay. I'll kick things off here. I will nominate Teresa Taylor to chair this fine committee. And do I have a second? Seconded by Director Rubacava. Any discussion on the matter? Any second? Okay. Oh, yeah. Any further nominations? Any other further nominations? Any other further nominations? Okay, at this point, any discussion before we call a question? No? Okay. I'll call the question. All in favor? Aye. Any abstentions? Any nays? Oh, I guess I've got to give up the gavel now. Congratulations, Teresa.
Thank you.
There you go.
All right. Still on? There we go. All right. With that, I am going to call for nominations for David Miller. And I'm going to go ahead and nominate David Miller. Are there any other nominations? Any other nominations? Any other nominations? I do need a second.
Second.
Seconded by Michael DeToy. All, for vice chair. Is there any discussion? I want to make sure nobody's having any questions. All right. All those in favor of electing David as vice chair of the board governance committee? Aye.
Aye.
Any nays? And any abstentions? All right. Congratulations, Mr. Miller. You are now vice chair of this lovely committee. And I think we move on to the executive report. It's such a tiny little committee.
The executive report is that I think you've already done the heavy lifting for today in this committee, so you can call it a day after you take the technical votes here.
Yeah, and we will take suggestions for governance committee at any time. But at this point, then, if that's the case, thank you, Mr. Jacobs. We have agenda item number 4, which is action consent, and yeah, okay, it's moved by Mr. Miller.
Second.
Seconded by Mr. Rufino. All those in favor say aye.
Aye.
All those opposed? And any abstentions? And then we move on to our information consent item, and that actually would be you? I see it's a consent item. Are we going to go? Yeah, any questions, anybody?
Sorry.
Okay, it looks like, yeah, this is just our education, so, all right. All right, so with that, I don't even see that we have a summary of board direction on my directions here, so.
It's on there, isn't it?
Oh, there it is. It wouldn't open, sorry. I don't think you got any, but summary of committee direction and public comments. All right, thank you all very much. We are adjourning the meeting of the Board Governance Committee. We will reconvene tomorrow for Board of Administration at 9 a.m.
Well done. That was a tough one.